Il est rouge, il faut le dévaler.
Absolument. Dear colleague, dear pediatric surgeon from everywhere in the world, it's a huge pleasure to be here in Strasbourg, and we are very honored by the presence of the president of IRCAB, Jacques Maresco. we are representative of the two main international society in minimal invasive surgery for children. And thanks to the extreme kindness of Jack and Irkad, who offered this possibility to have a webinar with a session for this afternoon, we will have a very, very great acknowledgement for them. Not only Irkad is very known about the performance in many areas of technical evolution and one of the most famous around the world for minimal invasive surgery educational program, but also the presence of Jacques Maresco as the president is very, very precious to have a short saga of the Institute. We are very happy to be here. Please, Jacques, could you tell us something?
Thank you. So, il faut que je regarde là-bas. So thank you very much, Professor Montopé. Just to say that for IRCAD, I think it's a very important day today, because you know that we welcome the pediatric surgeons since the beginning. That means 1994, more than 20 years. And the fact you have your first common joint meeting between the IPEG and the European Society, I think it's a very emotional moment. So I just want to describe very quickly, IRCAD, what we have done and what are our projects, because we have a lot of projects. So you all know that IRCAD was born more than 20 years ago, and that was due to the birth of minimal invasive surgery. So in each project, I think that if we want to have a success, first of all, we need to be at the exact time. And I think it was the exact time. After that, it is important to have a good idea. I had not a good idea, but I have copied a fantastic idea from this man, Rick Satava. Rick Satava is a visionary for me, and I attended an exceptional lecture in 1991 in Cologne, in Germany, and he has explained in 1991 the future of surgery about virtual image, about internet, augmented reality, robotics. Nothing existed at this period. But when I came back, I said to all my co-workers that it was important for us to build an institute totally dedicated to this new technology, because it was impossible to develop that in the National Agency of Research, INSERM or CNRS, and that was the beginning of IRCAD. Also, something important, we need to have a great environment. Strasbourg, especially when we come back from China, it's a very little city. It is a city of less than 400,000 inhabitants. But it is like in Germany, little city, huge and big university. It is certainly the greatest university in France, with more than 45,000 students, especially in science. And so it is because we have this great environment that it works very well. That is just a joke to say that when we are, especially a surgeon or a physician, we need to know a lot of things about business. And that is not a joke. That was my business plan 25 years ago. When I came to the bank to have the money, it was with one post-it. And today, I think it would be totally impossible. But I came to the bank, I had the money for that, without, nobody asked me more details about the business plan, and it was a lot of money. Why? Because one man trusts in the project. This man is Léon Hirsch. I think majority of you know this man. He was CEO of United States Surgical Corporation in New York. He was also a visionary, and it was at this period nearly a familial company. So it was very easy to work with him, to work with his wife, and he was the first one to trust in our project and to give the first money. It is the reason why the big auditorium, the first one, is named Léon Hirsch Auditorium. I think that is very important, because at this period, without somebody like that, it was totally impossible to do. One word about the project. I don't want to enter into the details of research, but everything since the beginning was to imagine that one day an operating room will be exactly the same than a cockpit in aeronautics. And you see that when we see the cockpit, we are very proud, it's nice, etc. And the operating room looks good. but it is the prehistory of operating room, because the next step of the operating room will be the integration of image in the operating room, what we call a hybrid operating room. And you see that in this kind of operating room, we need to have everything, to have the map, to have the 3D reconstruction, to have an augmented reality, all these details which exist in a cockpit of aeronautics. And more of that we have seen, especially in our specialty in digestive surgery, but I think it will be exactly the same for you in pediatric surgery, a fantastic evolution when we speak about minimal invasive surgery. Today we speak about minimal invasive surgery. Majority of people think it is laparoscopic surgery, but they forget the big evolution of endoluminal surgery, percutaneous surgery, and all that centered by robotics. One example for us for endoluminal surgery, that is not for pediatric application, but for an adult surgery. Last year was the first time in Japan where they have operated more gastric cancer by endoluminal way, by the flexible endoscope, than by conventional or laparoscopic surgery. And it will be the same evolution for rectal cancer, for colonic cancer, for a lot of applications. So that is an evolution, a natural evolution. And we have spoken about the image, the importance of the image. We believe that in the next step of surgery, we will have robotics, and we will add not only artificial intelligence, but an augmented vision. And to have an augmented vision, which is augmented reality, we need to see in transparency the organs. And that is possible. And you know that that was the idea in neurosurgery more than 20 or 30 years ago. And it was simple in neurosurgery because you do the CT scan, you operate, you fix the brain, and after that it's very simple to have the fusion with the image of the preoperative CT scan. In our specialty, in your specialty, the first thing we do, we put a trocar, and immediately the organ has not the same position he had during the CT scan. So we need to have in the operating room a machine, and the machine has to explain to the computer what is the new position of the organ. That is the concept of an intraoperative imaging. And that was the second project of IRCAD 4 years ago during the call, the international call by the French government. And we have created, just in front of IRCAD, a new institute totally dedicated to image-guided minimal invasive surgery. It is a pilot trial. That means we don't know if it is true. You know, there are no experts of the future. Perhaps it's not true. But it was the most important investment of Siemens in France. And we have research, education, but we have a platform for patients with 9 hybrid operating rooms. So that is a concept of, I hope you will have time to visit with this building with some very nice room for flexible endoscopy, for robotics, laparoscopic. This one with intraoperative MRI, but also you will see we have the MRI, we have the Zygo, I will explain what it is, we have the CT scan, we have all the different machines in the same operating room. It is a pilot study because it is very expensive. What we have to do is an economic repercussion to see what the society is able to pay, what is the best system, and which can be reproducible. So that is the next step of our project. And to look how it works, for example, for pelvic surgery, the patient can have an intraoperative CT scan. So you have the arteries, the veins, the ureter, you have everything. But we know that more and more by the new generation of MRI, we can see all the details of the plexus, of the nerves. And so we can have the nerve by this, what we call tractography. And after that, during the operation, we have this fantastic machine, which is a robotized CT scan. And in 1 second, you have 360 degrees. So in 1 second, you have an image of a CT scan. But the image is not a good quality because you have very few irradiation. But these machines are so intelligent, they take in real time all the data of the preoperative CT scan, the MRI, and they do immediately, in less than 1 second, the fusion of this image. So it is a fantastic development. One word to finish about the training center, that where we welcome always. So we have to say that we welcome also the pediatric surgeon for research, because François Beckmer, who is a professor of surgery, of pediatric surgery in Strasbourg, work a lot with the team of computer scientists for 3D reconstruction. He has a lot of number of good case for lung surgery, liver surgery, big tumors. Training center. Training center, we have one auditorium, a second one, equipped with a lot of transmission. You have to visit the new regies that we have for the audiovisual team. It's like a TV channel, very important. When we travel in the world, we see that sometimes you have one, maximum two audiovisual technicians, but education now is through all these techniques. That is an example of today with the streaming that we do. So we need a big team of audiovisual technicians. The lab, which has been totally renovated last year, it was from the 1st of August to the 15th of August. So, you know, in France, normally in August you don't work. So it is possible. I think when you pay at the good moment, everything is possible. It was done with more than 30 companies working for that. It's really very nice. After the visit of Gary Gotthard, which is the CEO of Intuitive Surgical, he decided to do the most important training center of robotics in Europe, and we have 10 robots here. So that was also done very quickly, in 2 months. Also to explain, that is important, in 2 months or in 2 weeks, I always say, because even if we are an academic center, only with professors, it is a non-profit private system with a big partnership with a company. And we know that when we deal with a company, we need to do immediately. We cannot say, oh, we are waiting the scientific committee of the university, which is taking place in 3 months, and after that discussion. No, we need to say, yes, we can, and we have to do. Just now we extend the course with a lot of course for flexible endoscopy, because it is more and more important, and I think it will be also more and more important for your specialty. Courses about image, 4D ultrasonography, percutaneous surgery, and just to see an evolution that never we had imagined at the beginning. At the beginning, when I was speaking in front of the politician to have the money, I said, we are going to train 200 surgeons per week. And I say, oh, they are going to see that I lie, because Strasbourg is a little city. Why 200 surgeons will come in Strasbourg? You see that in 2 years ago, and last year it was a little more than 5,000 surgeons come in Strasbourg per year, coming from more than 120 nationalities, just to show that it is possible when we say, and more. Very important also for your specialty, web search. We have understood that it was important to keep a link between the surgeon coming here and when they are back in their hospital. So it is a very, very good virtual university with more than 2,000 video, high definition, translated in 7 languages and free of charge. And that is very important for us, because we know that in some countries they thank us because it is free of charge, and even $200, they cannot pay $200. So that is also a very big and a good marketing tool, because when we put an announcement at web search, we have today, you see, more than 300,000 active members. That means surgeons connected on web search. So just to say that the success of IRCAD was a success of a good partnership with company. In new technology, in surgery, we cannot work without a company, because we have not the money. And a normal university, I think even in United States, cannot pay with, for a lot of this new technology. So important for us, for the funding, to be at the cutting edge of technology, to have the obligation of performance and excellence, because, you know, in France, we can be professor of the university all our life, even if we prefer to play golf. But with a company, if we don't work correctly, they are not going to support us anymore. And very important also for the research and development, we need to work with a company for research and development, because they know how to transfer, so it's a speed up for technological transfer. And I think something more important, it's important to have, even if we are in an academic environment, to have a culture which is a culture of entrepreneurship, a culture of the company. To finish globalization of the concept, in France in 1994, in Taiwan in 2008, in Rio de Janeiro in 2007, no, yes, Barretos 2011, that is Sao Paulo, and Rio in 2016. And just one short video. So in Taiwan, I know that you are all going also for education in Taiwan. It's a very nice center in front of a hospital with exactly the same concept. We have in Brazil, it is a very nice system in Barretos, state of Sao Paulo, middle of nowhere, only ranch, cows and horses, and the best hospital for cancer of all Brazil. They have free of charge for everybody, done for poor people in Brazil by a billionaire who expends all his fortune for poor people. It's something really very, very strange. And in Rio, it is the American Hospital of Rio. The only one, I think we cannot do that in France, with 3 entries, first class, business class, and economic class, but we cannot do that in France, where we go in jail. And that is the final project I'm going to discuss next Tuesday in Shanghai. So it's a Chinese program, you imagine that. So they want to create between 5 and 6 IRCAD in China. We asked to extend IRCAD. It was only teams who come in IRCAD, who say we want, and we will see. We have no decision today. So thank you very much for your time. It was a little longer than was I planned. My dear Philippe, I say 10 minutes, it was a little more. But I want to thank you, especially Philippe Montupé, because I think that what I have seen and understood what you have done to put together these two societies, not together because each one keep his name, but to work in the same direction for education, research, etc. That is the only way, I think, to do, because we cannot imagine a competition between two societies who have exactly the same goals. So I think, thank you a lot for what you have done.
Thank you very much, Jacques. I think the only word I have to say regarding IRCAD and yourself is a definition of IRCAD, the word excellence. And it's on a lot of publication and of advertising for IRCAD. I think it's very true. And also, one of your slides showed 3-4 rings, different color, absolutely like Olympic game. That is, all over the world, the excellence of IRCAD can be compared, and probably IRCAD is a winner in this competition in minimal invasive surgery. But also, if I can add something, it's yourself, Jacques Maresco. We know together for 22 years at the beginning of IRCAD, and what I observe, and you are very modest despite your huge ambitions and success, is your friendship. You trust anybody, any kind of body, and you are upper any kind of jealousy of personal ambitions, and that is a key of your success, I think. And that's why you were agreed by every community in pediatric surgery to support and to help this first webinar in minimal invasive surgery in children between the two main international society. One of them is the IPEG, 25 years of existence. The other is ESPES, the European one, 6 years of existence. And their boards decided to work together for educational project step by step. And here is the first step after a workshop, wonderful, organized by Professor Thiel in Graz 3 weeks ago. And now the webinar, we, all of us, we would like you will be interested. And Professor François Beckmer, who organized IRCAD courses all over the world, is now presenting our afternoon session. Thank you very much, Jacques, for your support, and it's for life, and it's an exceptional pleasure to be here. Thank you.
Thank you, Philippe, for this very nice talk, and thanks a lot to Jacques Maresco for inviting us here in this place, in this marvelous place we know now from 1994. And But we will begin now, and we will have 3 different topics. The first one will be about gastroesophageal reflux treatment by laparoscopy, and we will have 2 experts about this topic, David van der Zee and Philippe Montupet. The second talk will be done by Holger Thiel and Paul Philippe about inguinal hernia repair, using laparoscopy, of course. And the third talk will be presented by our colleagues in urology, but they are a little bit late. But don't worry, they have 2 hours more to arrive, so we will sure they will be on time. And it will be Philippe Savet. He will speak about trans or retroperitoneal approach for pyeloplasty. And it will be Ciro, our friend Ciro Esposito, who will speak about the trans or retroperitoneal approach for a total or partial nephrectomy. So we have 3 wide topics. These experts will give us a talk, short talk, and then they will answer, and that's probably the most important, they will answer your questions. And we know now you are coming from everywhere in the world. You are coming from Egypt, from Chile, Australia, Pakistan, Tunisia, Athens, Greece, and so on and so on. So thanks a lot, and please don't hesitate to chat with us. You will ask your own questions, and we will take into account your questions. And if we need other questions, we are 3 chairmen, and we will present by ourselves. And these chairmen will ask some questions, regulate the debates. And please, the first one is Dan Osley, who is coming from Phoenix, Arizona. Azi?
Good afternoon, everybody. Yeah, I'm Dan Osley. I'm here from Phoenix, Arizona. I'm the Surgeon-in-Chief and Chair of Surgery at the Phoenix Children's Hospital. I'm representing the IPEG membership and very excited to be here in this collaboration. Expect a great day.
Thanks a lot for this very long trip for coming here in Strasbourg.
Hello, everybody. I'm Mario Mendoza, pediatric surgeon and chief of department in Bellinzona, Switzerland. Very happy to be here, and thank you very much to the IRCAD and Professor Marisco for inviting us. And I'm representing the group of ESPES as a moderator.
Thank you. And I am François Beckmer from the IRCAD Center. I belong to ESPES group. And sometimes I belong to IPEG group too, so that's good. And we are very happy and very glad to welcome our colleagues in urology, Philippe Savet and Ciro Esposito. But they have time because we will begin now by gastroesophageal reflux treatment by laparoscopy, and David van der Zee will begin this session. Please, David.
Yes, Mr. Chairman, thank you very much for this very kind introduction. As the president of IPEG, I would first like to express my gratitude for IRCAD, Professor Marisco, to facilitate the organization of this wonderful webinar we are having here this afternoon. And also, of course, Philippe Montupet, because he was the initiator to get this together with ESPES. And I hope that everybody will enjoy this afternoon and have a nice meeting together. And please do ask questions if you have so. So first of all, we are going to talk about anti-reflux surgery in children. I will start off with a short video. As you know, there are 3 key points in this procedure. First of all, you have to bring down the distal esophagus back into the abdomen. The second part will be to reduce the size of the hiatus. And the third part will be to ensure that the distal esophagus stays in the abdominal cavity by applying the fundus against the distal esophagus in some sort of way, either 360 degrees, according to Nissen, posterior part, the toupee, or the anterior part, like the tile procedure that you are seeing right here. So while this is going on, you can see we dissect the distal esophagus, we dissect the hiatus. You can see the posterior vagal nerve that we keep there. You can see the aorta at the back. So after completing the first stage, that we have a good part of distal esophagus intra-abdominally, we perform a reduction of the hiatus with non-resorbable sutures. We use Ethibond, Shrio, and we make sure that in the distal esophagus we have a tubing, depending on the age, 8, 9 or 10 millimeters, to ensure that you have not a too tight closure of the hiatus. And then afterwards you can take the tube out. You can see also we have a vessel loop there to ensure that we know where the transition is between the esophagus and the stomach. And we perform a TAL fundoplication, anterior fundoplication, in 2 rows. The first suture goes on the left side, halfway the intra-abdominal part of the esophagus, and the second part is including the ridge of the diaphragm at the hiatus to ensure a complete closure of the fundoplication on the anterior side. So depending on how much you go around, it will be a 180 or a 270 degrees, somewhere in between. You have a proper solidification of this distal esophagus to ensure that it will not go up anymore. So what do we know about anti-reflux surgery? In adults, we have many randomized controlled trials, we have many meta-analyses. However, in children, it's poor. We just recently published 2 meta-analyses ourselves, but there is very little literature about that. Mostly these are retrospective studies, there are case reports, and there are no assessment tests. So what do we know? We do know that a child is not an adult, because 50% of our patients is neurologically impaired. They have an immaturity of the esophagus, and there are no normal values available for the pH study. Those are the symptoms we mostly see in children: vomiting, abdominal pain, resistance to feeding, weight loss, irritability, retrostomal pain, or hematemesis in exceptional cases. Now, in pediatric surgery, anti-reflux surgery is the most frequent performed procedure, but they have complications, and in the long run, it may even have Barrett esophagus developing. So it's important that we deal with it. So we did a systematic review on the effects and efficacy of anti-reflux surgery in children with gastroesophageal reflux. And you could see that there was a median success rate of 86%. There were, however, no studies using reflux questionnaires. There were only few studies with a GI function test, and the outcome was that the partial fundoplication had less postoperative dysphagia. So we did a systematic review. You can see it on the left side here, how we came from over 900 literatures found in PubMed, Embase, or the Cochrane, and we ultimately ended up with 8 studies that we could perform this systematic review on. You could see it if you would look at subjective reflux symptoms. There was no difference between a complete or a partial fundoplication. If you look at dysphagia, there was a clear advantage for the partial fundoplication with less postoperative dysphagia. And the number of dilatation years for the dysphagia was also very much in favor of the partial fundoplication. So partial fundoplication is superior to, in respect to similar reflux control and less postoperative dysphagia. So what about the TAL? Most studies only have a limited follow-up. What about the long term? So as we started our laparoscopic TAL fundoplication 15 years ago, we decided to collect all our data prospectively. And we are now able to perform a follow-up study for 10 to 15 years. So between 93 and 98, we did 75 cases. And this is the scheme of how it went. Initially, we had questionnaires and 24-hour pH study. And we had a follow-up after 3 to 4 months, 5 years, and 10 to 15 years with a questionnaire and a 24-hour pH study in 41 of these 57 patients that we could round up. So what you could see, if you would look at the reflux symptoms, you could see there was a a significant reduction of reflux symptoms after 3 months and even less after 1 to 5 years. However, you could see a slight increase again after 10 to 15 years. And if you would take this in a Kaplan curve, you could see that if you look at the loss of patients you have, because a number of these, particularly neurologically impaired children, they die for several reasons, that the ultimate outcome is not that good. It's only about 60%. So if you look at the total acid exposure time in percentage, you could see it as we saw before, the 24-hour pH study, after 10 to 15 years, a slight increase again. However, if you look at the patients with a pathological reflux, there is a huge increase. So that means that although the huge amount of reflux they initially had, they still have a recurrence of some pathological reflux after 10 to 15 years. So dysphagia on the short and long term remains very limited, 4 to 6%. However, on the long term, reflux control is not that good. So what way to go? pH study and reflux questionnaires are not enough. So we did a pilot study on 10 patients with GERD proven by pH study endoscopy. It was refractory to medical treatment for more than 6 months, and we did a laparoscopic tile fundoplication in all these patients. We did a reflux symptom questionnaire, we did a modified Demeester symptom score, we did a stationary sleeve manometry, a 24-hour combined pH and impedance measurement, and this was the outcome. So you could see, sorry, go back. You could see that there was a huge reduction of symptom score. However, there were 2 patients that had persistent reflux symptoms and 1 that had a transient postoperative dysphagia. If you look at the manometry, you could see that there was an increase in postoperative less pressure. However, this was not significant. And when you look at the acid exposure time in percentage, there was a good reduction that was significant. If you look at the combined pH study, you could see that there was a significant reduction in liquid and acid, but the weekly acid reduction was not significant. And then again, also if you looked at the gas combined pH and impedance study, there was some reduction, but it was not significant. So you could see that there was an increase in less pressure, although not significant. There was a reduction in total number of reflux events, which is important, and a reduction in acid reflux time. However, there was no reduction in the weekly acid reflux, and gas reflux was infrequent. So we now did a prospective study including also a 13-carbon octanide acid breath test to evaluate the gastric emptying. And we did a new study that is called the 3-dimension the ultrasound from the stomach to determine if that's an influence of reflux. And we are currently performing this prospective study looking at the efficacy of anti-reflux surgery and identify parameters for failure. Now, if you look at the effects and efficacy of laparoscopic fundoplication in children with GERD, the prospective study we published recently here, and it will be on the internet. It's available on the internet already. And also, what was just accepted for publication, the questionnaire of quality of life that shows that there is an improved quality of life with these patients. So this is for me my part of my presentation, and I would like to give the word to Philippe Montepé to talk about his presentation. Thank you.
Thank you very much, David. We know you were involved in the field a long time ago, and now with the most modern investigations, which are alone to prove the interest of the result of techniques with multicentric study. This picture is from an IRCAD book that is a symbol of working together, and that is a symbol of our meeting today. And if we started with GERD and laparoscopic anti-reflux surgery, and I congratulate Dan Osley because he published a lot of papers and is very interested as moderator too. And that is because the recent evolution changed our view, our indications, and maybe also our routine in terms of techniques. As everybody knows, there are three main techniques, and TAL was the most recent of them. And the first was Nissen, very popular around the world, but nowadays, Toupet's with recent literature is becoming more and more popular too. But LARS is composed by two steps: dissection and wrapping techniques. And as we saw on your beautiful film, in terms of TAL technique, the dissection is almost the same and is very demanding. That is one of our questions today, to insist about details for dissection. And another thing is there are neurologically normal children with their indication very demanding in terms of technique, but also in terms of parents' expectation, because these children are very healthy, except some reflux symptoms, and the explanation parents have to receive are very precise in terms of result, follow-up, contract, and the result for a long-term follow-up. Also, as David said, there are a few reliable randomized controlled trials, but now they are available, and it is changing our view on the reflux treatment. On the contrary, for neurologic impaired children, indications are also very carefully taken, with procedure more demanding, because these children are suffering very severe symptoms, and parents are afraid by other pathologies for them and are really demanding in terms of result. And for them, for ethical reasons also, it's very difficult to have randomized controlled trials. So as an introduction, I would like to say laparoscopic fundoplication has become the gold standard for the surgical treatment of GERD, but growing cohorts provide long-term follow-up, and among them a larger number of patients are presenting with symptoms of failed anti-reflux procedure. I agree, a lot of these studies concern adult patients, but the investigation of results are proving the same, and the failure rate range from 2 to 30, depending on the series and the definition of failure. What is the evaluation of the failure? Failure should be considered when patients present with recurrent, persistent, or new undesirable symptoms. And postoperative dysphagia is a new undesirable symptoms, a complication, a new symptoms when the patient's inability to swallow is so severe. This picture is from a paper of Humphrey, a large meta-analysis of adult series. And as you could see, in blue, it's preoperative symptoms, and in brown, postoperative, and in postoperatively, dysphagia and inability to vomit or to belch is a fear of parents especially. And we are searching a way or a technique or a team able to avoid this inconvenience. Surgical causes of failed are multifactorial, but it's agreed that in case of Nissen, migration of the wrap to the mediastinum is very often advocated. Just a few words about our experience, because she began at the first of the laparoscopic surgery and year after year, it's now a large series. But surgical indication from the beginning were based on clinical findings by pH monitoring and endoscopy, and commonly from the beginning by esophageal manometry. Our experience included a majority of Toupette's procedure, and the follow-up, of course, is now a long-term follow-up with a mean on 144 months. And manometric studies were performed systematically. It was like a contract when we accepted the indication with parents. Systematically, a manometric study was performed 6 months after the operation. Of course, 20 years ago, it was not so sophisticated as now MRI, but it was. And the result was exceptionally good for indication with normal children, non-neurologic children who were presented with respiratory, allergic, or otolaryngologic disease. Transient dysphagia occurred in 10% of cases, and recurrences reported in 2%. It's a little fewer than in the literature. So the result included reduced surgery in 1.8%, and the lot of follow-up was reported in less than 5%. Why? Because France is not a very large country like in the United States, and even if patients and family moved, we are advised if something is wrong, and because it's a major surgery, we are aware of the result. So it's a good follow-up. So we had to study how to reduce the risk of dysphagia and recurrences, and it was presented in the French Academy of Surgery and in Fukuoka for the IPEG Congress too. I would like to just to aware the majority of pediatric surgeon population about tools and means to reduce dysphagia and recurrences. First, to reduce the risk of dysphagia, an adjustment of pre-existing esophageal dysmotility. I quoted this excellent paper of David regarding the automatic impedance manometry, the same as MII, other tool in manometry. And this study may allow detection of subtle esophageal anomalies, potentially leading to post-operative dysphagia. On the right, it's a picture of a manometric study 10 years ago. Second point is identification and preservation of both vagal nerves. And this innervation is very important to preserve the motility of the esophagus and of the intestine. The third point is a stable wrap fixed onto the right diaphragmatic cruise, not at the edge of the hiatus, but really onto the fascia, the anterior fascia of the right diaphragmatic cruise. Fourth, flexible wrap, nasal tension, nor twist. It's allowed, for instance, by the translation behind the esophagus of the Toupette valve. And fifth, the wrap is overhanging in the right side of the esophagus without tension, because it's the anterior wall of the fundus which pulling behind the esophagus. And this overhanging does affect as a pneumatic valve and add to the stabilization of the wrap and also to the pressure on the low sphincter. Finally, the risk of recurrence. Also, it could be emphasized some points in this right way. The adequate calibration of the hiatus, but only adequate, because my master was François Dubois, who used to say, cruise sutures, cruise destroyed. And it makes sense. So, if there is a very enlargement of the hiatus, we have to tighten it. But if not, 30% of the cases, we don't use a stitch across the crura. Second, full mobilization of gastroesophageal junction, because one of the key, as it was proven by Juan Tovar and Boyce Ochoa in the past, is to have a good length of the low esophageal sphincter below the hiatus. Third, a rep anchorage again onto the right diaphragmatic cruise to avoid a migration up to the thorax, up to the hiatus. A symmetric positioning of the suture points is a balance, because after the operation, the gastric emptying and gastric filling, is like pulling down on the wrap stitches, and the symmetric positioning is a balance to have a good stability. And last but not least, the meticulous care to avoid excessive tight knot suture, and I think during the discussion I will have to redo this advice. And I thank you. It was just an introduction, and I hope a complementary to the excellent presentation of David. Thank you.
Well, Professor Enzi and Montpellier, thank you very much. That was a great overview of two different approaches to gastroesophageal reflux disease. I guess I'll start off with a couple of questions, and we'll see if we can get some questions coming from the audience, if everybody's okay with that. The first question I have, first of all, congratulations, David, for I think being the only person who's been able to do randomized controlled trials getting pH studies after doing the initial operation. That's something that we found very difficult in the United States to find a justification for doing the pH study in normal children. So that's an outstanding step forward in terms of understanding what the actual long-term outcomes are. The question I have to begin with is, you showed a great video looking at the dissection and mobilization of the esophagus, both you and Professor Montpellier. In our study, we obviously have shown that limiting the mobilization is significant in decreasing both the recurrence and the number of dilations and dysphagia. And then that includes the 5-year follow-up for the randomized controlled trial looking at minimal dissection versus maximal dissection. I'm just curious if you've changed your dissection approaches with regard to that study in your own anterior fundoplication versus posterior fundoplication in a manner that approaches what we showed, and if you've noticed any differences associated with that.
Well, then, thank you very much for the question. Actually, we didn't, because like I started to explain, the 3 essential steps that you take in dealing with reflux is that you have to bring into the abdomen adequately the distal esophagus. If you don't do that properly, you will still have a too short part that you can have your positive pressure zone that leads up to sufficient buffer for reflux to occur. So I think the proper dissection of the distal esophagus is an absolute necessity. And that in combination with narrowing the hiatus to a point that it should not be too tight, and that's why we always use an intraluminal stent. I said 8 for neonates, 9 for up to say 4 years, and over that 10 millimeter stents inside when you close the hiatus, to be sure that you have an adequate passage and that you have no stenosis that will lead to your dysphagia. The only issue I think that we did change in somehow was that in the hiatal stitch we used to take the posterior part of the esophagus. And that is something that we are not doing anymore, because maybe that may be an additional factor that may cause postoperative dysphagia, because it really fixes the esophagus to the hiatus, while if you fix it to the funds on the anterior side, it has still some mobility and you will have less symptoms of dysphagia.
So second question for Professor Montpellier. You also showed a nice picture of a fairly extensive dissection, and one of the comments you made was based upon adult adult studies early on that showed that you needed to bring in a certain amount of esophageal length in order to establish the lower esophageal sphincter, or the high pressure zone that Professor Van der Zee just talked about. The one question I'd have, or maybe the argument I would make about that, is that most adults, virtually all adults that have reflux disease, have hiatal hernias. And most children do not have hiatal hernias. They have a problem with their lower esophageal sphincter being incompetent, but they don't have the requisite hiatal hernia. So the adult literature was based upon reducing the hiatal hernia and making sure you had enough intra-abdominal esophageal length. And perhaps in kids we don't need to be doing that because there isn't that hiatal hernia there to have to manage that extra length. Thoughts on that?
I think so, because it's very interesting to compare adult and child in this point of view. First, I agree totally with the position of David regarding maintaining a full dissection and to have an intra-abdominal low esophageal sphincter. And probably one of the causes of recurrence described in the literature is due to dividing the short gastric vessels, because the weight of the spleen and maintaining the short gastric vessels is a way of stabilize the montage. And in my experience, I never divided short gastric vessels. And as you know, in the Nissen-Rossetti procedure, what is different from the Nissen original procedure is not dividing the short gastric vessels. That is one of possible causes of slipping up of the wrap. A second one is the girth of the wrap by itself. If you have a Nissen wrap, it's not so large as an anterior or posterior wrap, because it needs to have the girth of the esophagus into the wrap, and the wrap, the diameter is small and also can pull up. And last point is the anchorage of a large wrap onto the right cruise. It's like a verrou, a key preventing the ascension. And regarding what you mentioned about the dissection in adult and in some children too, it can be difficult in case of esophagitis, of severe esophagitis, but it doesn't in case of a normal child or a small child. And the dissection and pull down the sphincter is an easy dissection and is a key point of the success for a long-term follow-up, I think.
Thank you. Is there other questions?
Yes, a question coming from Egypt, from Rafik Shalabi. His question is, what type of suture do you use? What type of suture? Can you answer?
I think I said it already in my presentation that we principally use non-resorbable Ethibond 3 or 4, or depending on the age of the patient, sutures.
Philippe?
Yes, I use 2 Ethibond and non-resorbable suture. I just would like to add a short film, 1 minute, about dissection. And okay, and you see the dissection preparing the procedure and the Pyeloplasty with a tight. It's not tight. It's just approximating the 2 crura, no more. Because if we tie too much, we can destroy the fibers of the crura.
Maybe I can add, which is also very important in a dissection, and to if you make your fundoplication, there usually is a lymph node right on the border between esophagus and stomach, and you have to make your fundoplication above the lymph node in order to make sure that it will function. Because if you do it below, you will do it on the stomach itself, and it won't work.
One of my very respected faculty attendings in general surgery, who's the chairman of surgery at the Mayo Clinic, always used to say, approximate, not incarcerate. Yes.
I totally agree with what you are telling us, but the question is, in case of no hiatal hernia, no wide hiatus, is it really always necessary to reduce it as you do? And probably it's possible to leave it in some cases. And second part of the question, I know here in adult surgery, Bernard Allemagne add something between the two screws in order to avoid your knot to cut the screws, and it's a little pledget, vicryl pledget, that is introduced between the screws, and then it seems to avoid the suture to cut the screws. What do you think about that?
I think the good surgeon knows when to pull his knot not too tight. I mean, that's what we are surgeons for. Because I totally agree with Philippe that if you pull it too tight, you can see the color turns white, and it's not good for the cruré. Also, you should try to maintain the fascia on top of the cruré. Usually, people, when dissecting the cruré, they damage the fascia, and then you are purely on the muscles, and that will not be good either. So principally, I don't think it's strictly necessary to use pledgets. You should keep procedures simple, and introducing artificial material will make it more complicated. But if you know what you are doing, you should be able to avoid it. Also, if you would make, for instance, a slipping knot in the hiatus, you can adjust it just to the right tension that you would like to have it. And again, I think that is also an important factor, that if you know how to suture it properly and make it not too tight, you will probably not have this problem.
Yes, I can answer in the same way, and to add just a comment. Recently, for 2 years, I reduced the rate of cases where I put a stitch between the crura, because in laparoscopic surgery allows to dissect very gently and to avoid it at least 30% of cases to have a stitch to put into the crura. But there is an exception, a very important exception, regarding the neurologic patients. Because neurologic patients are submitted to suffering crisis with a big tension, and they can destroy some stitches, but also not the length, but the power of the crura are decreased. And in this case, every case of neurologic patient, not only I put stitches, but at least 3 stitches, very gently, but at least 3 stitches to assure the stability of the hiatus. It is the only exception.
Thank you very much. We have another question from a colleague from Iraq, Dr. Ali Mayov, who's asking if there is a special indication for one procedure over the others in infants, or special cases in neurological impaired childs. So I think what he means that if you have some advices, particular advices regarding the technique or modifications in your technique when you are facing a patient with a neurological problem.
Basically, you should use the technique that you are good in. So if you have learned the Nissen, principally maybe you should stay to the Nissen unless we can convince you sufficiently that a partial wrap will be better. Because that will guarantee your best results. If you start a new technique, you will have to go through the learning curve again. You will have to find all the complication that goes along with this new technique. I do agree with Philippe that the Nissen will give more dysphagia, and if you properly make your partial fundoplication, you will have much less of these complications. In neonates, particularly if you are talking about, for instance, children with esophageal who have severe reflux and do need an anterograph procedure, most of them also have a hiatal hernia, but they usually have a small stomach, so you don't have much to work with. So to make a Nissen there will really put it tight, and you will really get dysphagia also, because the distal esophagus is already having dysmotility problems. So there, a partial fundoplication will be best. Neurologically impaired children, in our experience, when many years ago we changed from the Nissen to the partial fundoplication, we noticed that the hospital admission time for these children really came down with 50%. The number of complications of RAP disruption, RAP migration, dysphagia, it went down 80%. So I think also for neurologically impaired children, they benefit from partial fundoplication.
I'll just make a comment about neurologically impaired children. When we performed the study looking at minimal dissection versus maximal dissection, let me back up 1 second. I think if you're going to do a Nissen, the data is irrefutable. You should not do a maximal dissection. There's no question about that. And I think both Dr. Van der Zee and Professor Montupet has made good points about why their techniques are better suited for more dissection. But the Nissen, you can't argue with the data with regard to that. So if you're going to do a Nissen, you should not do a maximal dissection. When we did do the study, though, the first study we had to randomize and for neurologically impaired children, because everybody had said, well, neurologically impaired children had higher rates of recurrent reflux disease after fundoplication, Nissen fundoplication, probably for the retching reasons that David was just talking about. Interestingly, what we found was that there was no difference in recurrent reflux in neurologically injured children versus normal children. When we went back and looked at it, what happened was that neurologically impaired children, when they retched, they got studied. People began to look for reasons why they were retching, and they found small hiatal hernias that were related to their previous operation, and they assumed that that was the cause of the retching, and they went back and reoperated them. When you study patients going forward, and for the study we got upper GIs at a year, there was no difference in terms of the hiatal hernia rates between the neurologically impaired children and the neurologically normal children. But there were differences in retching. That was probably a central region and not necessarily from the fundoplication. So I would reiterate what David has said, is that if you're going to operate on, or when you operate on neurologically impaired children, do the operation that you're most comfortable with, because it's going to lead to the best result.
That's very important what you added, because you are explaining us that if it's very different to operate, the way to operate Toupet, Nissen, or tile procedure, the dissection is not the same, and you have many differences. So that's the main point, how to compare these different approaches, because they are absolutely not the same in the dissection, in the manner to do, and so on.
We have to answer your fine question, but just before, I have some comment about neurologic patients. And you have this slide, it's a so recent paper, and I agree with Dan. Retching is very important as a cause of migration, as it was proved in a large series of pediatric series of redo procedure. And regarding neurologic patients, some points are to be fixed. The time of surgery, because if we operate too late this patient, after 3 years, after a lot of bronchitis, of pulmonary pathologies, increase the risk and the severity of the reflux, and the results are not the same. And the right time for the surgery has to be decided with the pediatrician in charge of this patient. Another thing is to operate these patients in a good status. And sometimes it's better to have a parenteral nutrition or an enteral continued nutrition for a while before to do the surgery. And of course, because these patients are fragile, are suffering a lot, and they are difficult, it's difficult to manage all the investigation for them. For instance, impedancemetry or some pH metry are difficult to do. And if they need a gastrostomy, and if we have a proof that the reflux is clinically or an upper GI series obvious, they need to have the technique of anti-reflux surgery at the same time. And the last point is, because these patients are fragile and the results are very, very expecting by parents, we have to take sometimes more time than for usual surgery. Time is not a problem for us in this kind of patient, and we have to be very, very careful, noting, suturing, dissecting more than in our usual surgery, maybe.
Could I also come back then to the issue between the US and Europe at least, or maybe even the rest of the world, on maximal or minimal dissection? Because in my opinion, if you want to, before you can do surgery, you need to make a right indication. And in order to make a right indication, you need to do proper preoperative research. And I think this may be an issue, because in my feeling is that in many of the studies where they did minimal dissection, they did not do very much preoperative research in determining the amount of pathological reflux. Now, for example, when we started off doing our anti-reflux surgery in the 90s, every patient that came for us for a gastrostomy, we did a pH study and they had pathological reflux, and then we did an anti-reflux surgery. But we had failures. And why did we have failures? Because a number of these patients did not have really gastroesophageal reflux disease. They had esophageal motility disorders. They had gastric outlet problems. And we actually operated on these children on the wrong indications. So in this sense, my question is, how can we compare what is better in minimal or maximal dissection if we are not talking about the same patient?
No, I think your point is completely valid. We know that pH and impedance in children mean really nothing, right? We looked at a subset of patients that were under 6 months of age and looked at their pH scores and their impedance scores, and they were 100% accurate in predicting reflux. But when we looked at those same patients that were managed medically and surgically, neither one of those scores, the pH or the impedance score, predicted which child should get a fundoplication. So we don't necessarily know we don't really necessarily know what studies should be the best study to predict the need for a fundoplication. And that certainly could have led to some results that may differ between Europe and the US. I think we're more aggressive in the US of doing fundoplications. We've tried to back away somewhat in that over the last 5 years, but certainly that inability to really clearly identify on a diagnostic test side what patient really has pathologic reflux, not the patients that have ALT spells or chronic pneumonias or a hiatal hernia, but the child who has just reflux disease and maybe isn't gaining weight and could have gotten by without a fundoplication with some other feeding route. That's really what I think is a great point that David brings, and I don't have an answer for it, but it's something that we should be looking at.
Regarding this topic, I remember, for example, in your case, Philippe, I know that you have a multidisciplinary team. When you get to the decision of the surgery, you already have your gastroenterologists, you have ENT surgeons, you have a very good multidisciplinary team to get until the decision of the surgery. What would you recommend for surgeons that don't have these resources, that they need to take the decision of the surgery in a patient with no hiatal hernia, but the clinic of reflux, it's evident? Which are the best exams or evaluation to make the decision for these surgeons that do not have the resources of a multidisciplinary team?
It's a partly a difficult question, because if the surgeon does have a team for investigations, and a good pediatrician not reluctant, for instance. That's a lot for surgery, and even in university centers, that pediatric gastroenterologists are reluctant to the surgery because they had bad memories, or something like that. So the surgeon interested in reflux has to organize by himself the team and to have a good referent in gastroenterology with, for instance, this kind of high-resolution manometry. It's usually it's good for the patient, but it's good for the team because the gastroenterologist able to make a right diagnosis will be rewarded by a lot of new patients. It's really a team. And I have a big chance, that is the cause of the big series I made. I had the big chance in Paris to have two teams excellent in private pediatric gastroenterology outside the hospital. So they referred a lot of patients, and they got a lot of patients thanks to the quality of their investigation. But it's an effort and a management of the surgeon with a good team.
Thanks a lot. I would ask this question coming from Christos Salakos. Everybody knows Christos. He worked for a long time in France, and he says that he has a question about neurologically impaired children. Does the fact that they may not eat by their mouth and they have a gastrostomy, does it change your choice for the type of surgery?
I have to confess, it may sometimes. No, I think if you have a child, again, what is most important, you have to determine whether they have no gastric emptying disorder. Because I think 30% of these children do have gastric emptying disorders. And they benefit more from a duodenostomy than giving them an anti-reflux procedure. Which is even a less complicated procedure for them as well. But if they have no gastric emptying disorders, in some cases when you are sure that they will probably be on a lifetime gastrostomy feeding, you might as well do a NIS fabrication in order to make sure that they have no reflux in spite of gagging and trying to retch. To avoid having them more pulmonological problems. So it is a not 100% watertight indication, but sometimes considering the patient's condition, it may be of benefit. And then again, I think also you have to decide, because when you really have to pull a Nissen tight in order to get it fixed, then rather do a toupee than try to get it around all the way. It should be a comfortable procedure. It should be snug. It should not be too tight, because that will ask for complications.
Because I think every pediatric surgeon interested by the field has to be trained with at least Nissen and toupee. And for instance, there is the recent paper of Miyano from Tokyo on a series of 131 patients, neurologic patients, and results were good. I have just to answer neurologic patients who had difficulty to swallow can be severely it can be a severe aggravation by the inhalation of the swallow and pulmonary complication. And if we do a tight Nissen to prevent the regurgitation, we increase the risk of pulmonary complication too. And it doesn't decrease the mortality. And I have to refer also about the paper of Bensoussan. It was in 1991, by open surgery. And he published more than 100, it was 111 patients operated by the two-pet technique, neurologic patient, with good result, because there is a balance between the risk of regurgitation and the risk of inhalation of the swallow and pulmonary complication. It's a balance.
Do you use, for instance, scintigraphy to study how the stomach is able to empty?
There are no reference dates for what's normal gastric emptying with scintigraphy studies. There are some normal values for the 13 carbon octanide breast tests. So they seem to be more accurate, and that is what we use nowadays for these patients to determine whether they have gastric emptying disorders.
I know some countries like Brazil, for instance, are very skilled, and scintigraphy is very accessible for hospital. But really, recent literature didn't provide papers about the interest of scintigraphy. It was in the past interesting in terms of pulmonary inhalation of particles, but to evaluate the severity of reflux, it's not really used now, except for maybe some countries, I agree.
So I have a question, and actually there's the same question has been asked on the question stream here. What about redo fundoplication after failed fundoplication? Do you do the same operation?
It's interesting to see, because if you go back, usually you really have to take down all the sutures, and then you end up to see that the hiatal suture came out or some other suture came out, and you redo it, and actually trying to put on the fundo back again, you come back at the same spot for putting in the sutures again. And usually, they seem to have worked for some time, so apparently it is okay. So I principally don't change technique. Also, if you do it after a couple of years, the fundus has sort of less placated itself to this way, and if you want to transfer an anterior fundoplication into a posterior, you're turning and twisting the fundus, so you shouldn't do that. The only exception I have to make is that in the past we've had a few patients that had life-threatening events from pathological reflux in esophageal patients, and we gave them initially an anterior partial fundoplication, and they continued to have life-threatening events. So we went back and we made a Nissen out of that.
In the case of reduced surgery I had, more than 37, I was surprised by the easiness of the reduced surgery compared to in the past with an open way. And even almost all the cases, it was a shorter time for the redo procedure rather than the first time, because it was just to pull up a little bit the wrap and to redo the fixation and stitches. So a nice information to provide for parents at the first consultation for the primary indication of anti-reflux surgery is to tell the truth. It could happen in 2 to 5% of cases, a risk of redo surgery. But it's not a big problem if it happens in the very, very few cases. It will be so easy because laparoscopic surgery reduces the rate of adhesions and simplified the second procedure. It was always my own experience.
Returning to the evaluation, you were talking about manometry. And manometry is still a little bit, there is a lot of controversy because some surgeons are used to work with it. What is your experience regarding the results of manometry for neurological impaired patients and also in children with esophageal atresia and children under 5 years, where it says that the manometry probably is not very well evaluated.
First, for neurological patients, manometric studies are more complicated to manage and to organize. But also, we know the majority of these patients have poor motility of the esophagus. So that can be checked by a manometric studies, but it's not so important because it's poor. And it's absolutely the same regarding esophageal atresia. And in case of esophageal atresia, I advocate to perform a partial wrap, avoiding to add a pressure around the low esophageal sphincter in any case of esophageal atresia. But for them, because the delay to operate it on is about 1 year or 6 months, it's a good time to perform also a manometric studies in the goal to compare the objective result in the outcome after the operation. But for neurologic disorders, it's difficult to manage it. It's not always performed.
Thank you very much. In case of a very large hiatal hernia, did you never use a patch, and what kind of patch?
I remember an 18-year-old, neurologically impaired, 150 kilogram girl with a huge hiatal hernia. And initially we tried to close it primarily. That didn't succeed, so we put in a patch. But I learned from my adult colleagues that 5 years later they had to really cut it out of the esophagus because it had progressed into the esophageal wall. So I would prefer to avoid putting in patches at that time. There is a nice publication not too long ago, if I can see my presentation back again, where they did a paraesophageal incision away from the esophagus. And then you can make a nice primary approximation of the hiatus, and you put your patch on this defect away from the esophagus, and then you have less risk of having this transmigration. Can I see I can show the publication? Yeah, let me see. So here is the publication I was talking about. It was published recently in Surgical Endoscopy on the use of a cruel relaxing incision with biological mesh reinforcement during laparoscopic repair of complex hiatal hernias. And I think this may be a way to go, because you make your incision away, it's safe, your hiatus is safe, and you just close the defect like you would have a diaphragmatic hernia further on.
So I think we have time for one more question. In the U.S., at least, I can't speak for Europe, but I would bet that the same conflict exists. There's been a recent push for children that have reflux disease to be fed in a jejunal route rather than do a fundoplication if they can't be fed in the stomach because of reflux. Do you have thoughts about that? Neither point of view. I have my own personal thoughts, but I'd love to get your guys' thoughts.
You have a number of kids that don't tolerate any feeding by mouth or by stomach. While if you advance the tube into the jejunum, they can be fed, they can grow adequately, they can increase their weight, they come into a better general condition, and in most of these kids it becomes clear that after a couple of months or maybe some years, they will be able to tolerate feeding over the stomach and even have oral feeds later on. So it certainly is an issue to look into and to have in your mind when you have a patient that you can't feed in any way possible, just to get them into a better feeding condition.
What about the patient that you can feed in the stomach, and they don't have delayed gastric emptying, but they just reflux. So the people, there are individuals that advocate, because of the complications of anti-reflux surgery, that we shouldn't do fundoplications, and children should be fed jejunally rather than risk the complications of fundoplication.
No, I think particularly doing it minimally invasive, the rate of complications has gone down significantly. So, of course, you will always have people against some technique, but I think that we could generally say that a fundoplication is a good procedure on a good indication. I think we discussed this extensively today. And then in those cases, it's worthwhile carrying out the procedure to have these kids be able to eat properly.
Yeah, I agree. I don't think a child should be subjected to drip feeds, 20 hours a day when you could bolus feed them in the stomach after a fundoplication, especially given the data that you two have shared with us today. I think that's very true.
I would like to ask a question about, because we didn't say anything about these two various techniques. What about cells for gastroesophageal reflux treatment? Is there a place? And what about the robot, please? Your opinion.
I'm afraid I'm not smart enough for either cells or robotics. No, robotics could have a place, particularly nowadays if you have robotic cells. The robot, he calculates for you what to do with your instruments, and you do a normal, more or less normal procedure. But usually if you have a kid of 10 kilograms, I wouldn't put a robot in that, actually. And cells through the umbilicus, you will have to extend the incision, even if you don't use trocars or the special cells trocar, and just put in the instruments through the fascia. You're mingling with your hands. Sure, it can be done. There are publications, but I'm not smart enough for that.
Of course, I have no more experience as you, David, regarding robot or seals procedure by myself. But I remember 7 years ago when a senior young woman pediatric surgeon joined us in our hospital in Bisset. She had performed 50 robotic Nissen, and she restarted with me for noting laparoscopically. And what I have to say is the evolution will change something in terms of robot and in terms of size of the instruments, but also we have to say the LARS, laparoscopic anti-reflux surgery, is the best training in terms of noting, because at least we have 7 to 11 stitches to put rightly, carefully, under control by a senior surgeon. And if the indications are good for laparoscopic surgery, it's an excellent training for surgeons, even if robotically it can be easier, like this paper from Lund in Sweden, proved a comparative series, 80, and it was advantageous, but today it's not proven, of course.
I think we are now transgressing into another discussion, because you mentioned training. Training should be outside the patient. We nowadays have excellent pediatric models where you can train excellently in learning how to tie knots. But I disagree. I think robotics is, we sometimes make a joke, robotics is for people who are less good, because they need the additional force of freedom to be able to make a good knot. If you're a good endoscopic surgeon, you can do it. You can make a perfect flat knot that will not slip. But again, we nowadays have excellent training courses where we have fantastic models that you can train performing good knots in. And I don't think that should be an indication for robotics.
David, I'm sure it's impossible we fight each other, and I agree with you, because my poor English, I use training, but I mind skill increasing. And of course, when you are 30, 35, 37, you are trained on the specimen or in the lab, but you are not so skilled in noting. And it's a way to improve the skillness. I agree, not the training. I agree with you.
Thank you very much. We have a question from Pakistan. They are asking if pyeloplasty can help in retching, if there is a role of pyeloplasty to avoid retching.
There have been studies performed by excellent centers who do a lot of research in gastric emptying disorders, and pyeloplasty has no place.
The same.
Well, thank you very much. We would like to thank Dr. Van der Zee and Dr. Montupé for sharing their experience in this very interesting topic. And then we're going to move to the next pathology, the next presentation, which is in the last 10 years, probably one of the pathology where most of the surgeons have expressed a lot of creativity, let's say, because the amount of techniques that have been developed in minimally invasive surgery, it's very, very important. So it's going to be Dr. Paul Philippe from Luxembourg and Dr. Holger Thiel from Austria that will take care of this presentation. Please.
Paul?
Well, thank you, Mario. And basically, we were here to have a debate, but he's such a good friend that we cannot fight. So we are going to do a shared presentation on this, and I will ask him to stop me whenever he wants to place a word, if he can. Well, does it make sense to consider laparoscopy in inguinal hernia repair? This is probably the most common procedure that we do. It's a time-proven operation that relies on one basic principle, which is the high ligation of the persistent patent processus vaginalis, which occur for the vast majority, many things, all inguinal hernia in children.
Yeah, well, most of you, good evening, good afternoon, are familiar with that. In open surgery, there are 2 or 3 key points. The one is the generous mobilization of the vas and vessels of the PPV. We come back later on why that is essential. And then in cases with huge internal or external inguinal rings, some kind of reconstruction, according to Bassini or others, of that. Why are we, Paul and I, saying that? Because you will see later on in laparoscopy, these 2 key essential steps in open surgery are a matter of debate or neglect. And we already asked the question, is this as important as it is? And then can the laparoscopists do it as well? Or is it not important? Paul?
Now, if we look at the conventional herniatomy, it's a basic surgical procedure that is carried through a 1 inch, 2.5, 3 centimeter skin crease incision, short. It's a daycare procedure, minimal postoperative discomfort. Unlike gastroesophageal reflux, the benefit that you would expect from the shorter trocar incision is certainly less. There are very few complications, and as pediatric surgeons, the rate of recurrence is extremely low. This is an easy, quick operation with no complication, so why should we change the winning team? Yes, I'm from Belgium. Is it really an operation without problem? Recurrences, we believe 0, but in the literature you find a lot of papers with up to almost 5% of recurrences. Now, cosmesis, we are all good, but this is the type of patient that we sometimes see in our hospital, in our pediatric hospital, with this type of scar. And another problem that has not been solved, that's a metachronous hernia on the other side.
But Paul, do you agree that later on in life this kind of cosmesis will not matter as much as any place else in the body?
I'm not sure if there are children listening, so I cannot comment.
Okay.
Now, the one problem in this open surgery is this: the dissection of the vas and the vessel, because a recurrence, we can fix it. But when there is an injury in the cord, it's for life. Testicular atrophy up to 3%, iatrogenic testicular malposition up to 3%, and the rate of vas deferens injury is impossible to assess during surgery. So this is why we both believe that there is a place for laparoscopy in the treatment of inguinal hernias.
Yeah, so the point we were trying to raise is, can we do better? And what kind of laparoscopic strategies would add to this already almost perfect open operation? Well, one thing is the open operation does not allow the assessment of the contralateral side. So one question we need to solve today is, does it matter the contralateral side, or precisely, what is the incidence of the so-called metachronous hernia? I translate that: how many kids do actually have a bilateral hernia and the other side has not been identified yet? And there are good data about that. Can we say about between 11 and 30%? We'll do that later. So looking at the other side during this one operation and only doing what is necessary, telling mom and dad, yes, there has been a bilateral, or no, there has been no need to worry about the other side, that could be already beneficial of the diagnostic laparoscopy. And once you're already looking, well, you may be as well touching, meaning you have two basic laparoscopic strategies how to deal with an inguinal hernia repair. Let's make it clear, they're different. The herniorrhaphy is just a closure of the PPV, of the peritoneum. And the herniotomy means to dissect it. We'll split that. I'll start with the herniorrhaphy, and then Paul, you would continue with the herniotomy. Yeah, just a brief background into the history. Let's give Tom Loeb credit. In 1992, he already said the use of the laparoscopy as a diagnostic tool is very, very valuable because you can easily assess the contralateral side. Many different techniques through the sac, through the umbilical, but we won't go through that. And then Mark Wilken in 96 already described 80 children with the successful diagnostic laparoscopy and the incidence of the contralateral opening of the processus vaginalis. Many different papers on that in those days where everybody became enthusiastic about the role of laparoscopy in inguinal hernia repair. As a German, we have to give credit and criticism at the same time to famous Felix Scheele, because he was certainly one of the pioneers in the area of inguinal hernia repair through the laparoscopy. In those days, he already did mini laparoscopy, 2mm instruments and a 5mm scope. And he did a Z-stitch, as it is shown in the drawing on the right side, across the peritoneum of the internal inguinal ring. Note, and that will be of importance for those techniques, that he had, of course, to leave a defect at the site of the vas and the vessels in order not to compromise them. One of my personal teachers and the gentleman that I always like to give credit in this business is, of course, C.K. Jung. And I had the privilege, as many of you know, to stay and work with him in 2004 and 2005. So in order to prepare for this web search, I contacted CK and said, CK, why don't you speak and why don't you give the authentic material? And he nicely delivered. So on behalf of CK, I'll report on his technique. What does he do? He takes a Reverdin needle, a little bit different, and arms it with a suture. That's a proline suture, non-absorbable. And with the laparoscope at the umbilicus, looking into this point of interest from the outside, he will later on, I'll show you in a drawing, then do a circumferential purse string suture with the help of a 2mm instrument. Clearly, the needle comes from the outside, it stays extraperitoneally, it passes on the inferior rim of the internal inguinal ring and then penetrates the suture. And then the empty hook goes on the upper border of it, just like it's seen here. And then you feed, with the one instrument, you feed the suture back into it and you pull it out. And here comes the video. That's one of CK's latest video. Like I mentioned, 11 blade just above the internal inguinal ring on the lateral side of the vas and vessel, of the vessels from the epigastric artery. And then the armed hook passes underneath the peritoneum on the lower side, on the inferior rim of the internal inguinal ring. Note in boys, we mentioned that you have to scrape off first the the vessels from the peritoneum, and then coming medially to the vas, you have to scrape off the vas from the peritoneum. If you don't do it, I'll quote CK in a minute, he says then you run a risk of compromising vas and vessels. Having done the inferior rim, you take the suture into the body, you retrace the hook, you pass it the other way around for the remaining part of the purse string suture. You make sure that you don't damage the epigastric vessels. You feed the loop back into the hook. You fix it. And then you retract hook and the purse string suture. And here you have the complete suture. CK pulls on the peritoneum intentionally to make sure that it's loose and floppy and that vas and vessels are not pulled into the suture to prohibit an ascending testis. He just recently, the next technique to compare with is the technique from Darius Patkowski. Here is Darius during a meeting in Braga where CK, Steve Rothenberg and others came, and he nicely explained his technique. And of course, as a gentleman of fun and fortune and wines, we had him dearly giving us his talk for this web search as well. What does he do different? It is again a herniorrhaphy, but more like the shear technique. Under laparoscopic guidance, through the umbilicus, he punctures from the outside with an 18-gauge needle, and through that needle, he feeds the suture. Again, a non-absorbable suture. He does several stitches on the peritoneum. Again, he leaves, just like shear in older days, leaves a small defect in males for vas and vessels to pass through. And with the so-called lasso technique, he then retraces the suture, pulls it outside, and knots from the outside. Here's a video in Polish. A crying baby. Obviously, he does that in smaller infants as well. Thanks, Darius. You promised to be watching. Thanks for the video. We all appreciate that. So that's the umbilical access. Is Darius on the net?
Yes. Yes.
Hey, Darius. I promised. It's you. So, a fine surgeon with a 5mm port at the umbilicals with an half-open access, installing the pneumoperitoneum, checking for the gas to flow, and assessing the left side and then the right side. The baby lies on its back and you're looking into the smaller pelvis. So that's the right side. He's checking for the adequate point where to do the puncture. And this is already the armed 18-gauge needle, puncturing from the outside under laparoscopic guidance through the peritoneum of the ventral side of the internal inguinal ring. Taking care not to damage anything like vas and vessels or the iliac internal artery. And then he does the inferior portion later. He leaves that suture inside later on and retraces it with the so-called lasso technique. Before doing that, he takes another puncture of the peritoneum, just like in a Z-stitch like. Now he advances the suture into a loop, retraces the 18-gauge needle, very elegantly does another puncture with a single suture through the same hole, not to create another scar. And certainly this is an invisible access from the outside. If you want to, you can take the ligament into the reconstruction, and now he feeds a single non-absorbable suture through the loop, and that way he can retrace the loop and tie it from the outside. Yeah, ladies and gentlemen, my task was to introduce those two techniques, and thanks to both original inventors, we had the pleasure of watching their videos. The question now is to Paul. Hey, Paul, can you do better than this, laparoscopically?
Well, if you go to laparoscopy, you will find yourself in a place that was already described as easier in 1953 by Bernard Duhamel, who proved and showed that dissecting the processus vaginalis above the inguinal ring, here with an open pre-peritoneal access, was in fact easier than within the inguinal canal. So if you can dissect the processus vaginalis up there, why don't you do it by laparoscopy? Now, the technique that we use is a 3-trocar technique. We use all 3 mm instruments, including a 3 mm scope. Is there a problem with the video? So only 3 mm instruments in the umbilicus and at the level of the lateral sheath of the rectus on both sides. The set that we are using is a common reusable set of instruments that we use for many other procedures, so there is no special expense, no special cost for this. I would even go to say that it is cheaper than the open repair, because all you need is one suture of 4 or 2/0 braided polyester and a set of steri-strips. Now, the surgeon are going to look down at the feet of the patient, and this is what they will see. Now, how to access the abdomen is controversial. We are faithful to the Veress needle, and we use low pressure, as low as it will allow us to see. Now, this is an older child with, there again, 2 openings in a unilateral presentation. Now, the technique that we suggest is to actually dissect and divide the peritoneum all the way around 360 degrees around the internal ring. Now, this part of the video is in fact minimally edited, and especially in this type of patient, this is a very quick procedure. And you see that you can actually have in your hand the entire processus vaginalis free from the cord structure. A little addition that we made to have a minimal recurrence rate is to resect a few millimeters of the sac in order to leave a completely raw area at that level. And then all you need to do is close the peritoneum, mimicking the closure of the processus vaginalis at the internal ring as you do in open surgery. With one difference, the vas and the vessels have not been touched. They are in their bed, free and safe. They are also safe because you see where they are and there is no risk of injuring them with a blind needle under the peritoneum. Oops, I said it. Now, I will not say that it is good for the training, but for the routine practice of knots that we all have. You know, the best singers in opera do their training every day, and this is the completed operation. And a happy patient. Now, I suggest to go back to the chairman and the moderators, and then we will gladly answer any questions that you have.
Thank you very much for this nice and wide presentation. There is a first question coming from Bangladesh, from Asharur Rahman Mitul, and he asks that, is it necessary to ligate the sac, or a simple excision of the patent process vaginalis may be enough?
Yeah, this is a wonderful question. And there are data for that. The British, like Muntaha, this is a wonderful question and there are data for that. The answer actually is, no, you don't have to. Whoa. I think most of us would not dare to leave it open, but we'll pull the data in a second, saying that no ligation, just resection, is in fact rather safe. And if you ask, for example, the British people how they do open herniatomy, they just cut the sac and don't ligate. What is, everybody in the room says, nobody feels comfortable with that, but what's the rationale behind it? The rationale behind it is the following. By cutting the sac, you create a surface of raw tissue between both ends of the sac, and that heals. There is a wonderful study, take a look at this, it's just being pulled, which says success rate of suture ligation and only no ligation, just resection. 91 patients, complete transection, no closure, no recurrence. And we can go on and on for that question. There is a very good question from very good study from Todd Ponsky in a rabbit model where he looked at the burst pressure after laparoscopic herniatomy in those animals, and he basically found a brilliant, almost zero recurrence rate after creating this raw surface. So in summary, the question is very good. Nobody would dare to do it, but you can do it, and there are data for it. Paul, what do you think?
Well, one of the comparisons that is often given is what we do with laparoscopic orchiopexy, where we do not make any effort to close the internal ring. Now, if we have time, I'll show you how to repair a hernia after that type of technique, because I had one after orchiopexy. The truth is, many series, even in the open ways of no ligation, are good, but they still have a 3 to 4 to 5% recurrence rate, which is comparable to the open conventional technique.
So thank you for your presentation. That was very well done. I like how you played off each other. One of the concerns that often is raised is how do you manage, or what do you tell families about postoperative hydroceles since you don't excise the distal sac completely? Can you give us some comments or thoughts about both counseling the families for the possibility, as well as how do you treat the postoperative hydrocele if it occurs?
Well, with the technique I suggest, where we do resect, divide completely and resect, I have not seen hydroceles.
Let me add to that, because to get some academic discussion on those matters, recurrence rates, hydrocele, atrophy, we prepared this slide. First of all, what's the gold standard? Maybe we go to the gold standard first. What's the gold standard that laparoscopy has to go against?
I need better glasses.
And the gold standard in open surgery is that open surgery is really good. So you're going up, if you take this study from Vogel's British Journal of Surgery in 2010, and I think it's still valid, because they looked at 3,128 herniatomies. And for open surgery in children, the overall recurrence rate was 0.06, wound infection 0.9, testicular atrophy 0.8, minimal incidence of hydroceles, and low injury to vas and vessels. Wow. So laparoscopy has to be as good as. And for a long time, it has not been. And I think that's why people who were excellent laparoscopists said, hernia is the least I would do. But we learned from them. We learned from Felix Schier that take a look at his personal historic results. In 1998, he was very enthusiastic. 0 recurrence rate. 3 years later, patient came back, 3.4 in his personal series, and then when he finished giving those data in 2002, already at 5%. So by time, these recurrences will develop, maybe not in the first year. But in his early series, he used absorbable sutures. So he learned from that and take non-absorbables. And then we learned from him that a roughy, at least not in a Z-stitch technique, may not be as good as. So the laparoscopic technique improved tremendously in terms of all of these data. Can I go on? Just to give you clear data, I presented the Young technique and the Pierce technique, and we prepared those success rates. Take a look at the Young technique, and just take a look at the title. Towards a near zero recurrence rate in laparoscopic inguinal hernia repair, published by Paul Tam, taking CK's technique into the next generation, or with a couple of technical improvements, TL, technical improvements, recurrence rate of the tension-less group 0.4. I consider this as good as open. And if you let's quote CK. Why is that so good? CK wrote a couple days ago this email to me, and I'm proud to present it. Let's read it together. The key of success to a complete tension-free and secure tight closure of the PPV is that you have no tension. This requires adequate dissection of the PPV of all surrounding tissues, like we mentioned in open surgery, with the hook. What I've found over the years is that if you can have a very secure closure, you don't need to divide the sac, as I suppose it will get ischemic or fibrotic, mimicking this open process of having a gap. But tension-free is mandatory, otherwise the knot will be not tight enough, and this will lead to a post-operative hydroceles or worse, to recurrence. So CK is down to 0, and let's give Darius credit. There's a study from another group about Darius techniques in 215 patients, 250 hernias, short operative time, short follow-up, recurrence rate of 1.4. And again, I'll quote Darius, who wrote last night to me and said, "Dear Holger DePaul, we're just preparing our latest data. So we operate 809 children, altogether 1,119 closures. And over years, he operated, and I think this is a very, very honest man, he found 39 patients with recurrences, 4.8% of recurrences in patients, and 3.7 for all 1,100 internal ring-like closures he has done. Yeah, is that as good as? Paul?
Well, I will just give a quick number from Luxembourg. We are up to 1,000 patients. Some of them were already published. We did have 5 recurrences. That's 0.5%. in the range of what is expected in open surgery. And 3 out of the 4 of the 5, one was just a little nuck cyst in a girl that you can see here, but all the real recurrences were attempted by laparoscopy, 4 of them successfully.
Mm-hmm. Thank you. There are many, many questions coming from the chat, more than 10 now in 1 or 2 minutes. So that's difficult to choose, but probably one of the best questions is, do you think that hernia repair should be the first choice for laparoscopy? Well, laparoscopy would be the first choice?
You mean that laparoscopy should be the way to treat
the way
hernias?
to do?
I guess it depends on your expertise and your enthusiasm. In my department, yes. Others, and I think Holger will discuss it, have specific indications. Holger?
Yeah. Common sense says, if there is an incidence of metachronous hernia between 10 and 30%, it does make sense what Tom Loeb already said many years ago. So my indications are, first of all, any child with a bilateral hernia, of course I use the laparoscope because through one access I can do both sides. If a child has a suspected bilateral hernia, again I will use the laparoscope to check the suspicious side and only do what's necessary. So bilateral cases, suspected bilateral cases. I continue. Cases post-incarceration. Open surgery, you don't check the bowel, but in laparoscopy you can easily do that. And finally, any kind of umbilical defect. So any operation, hernia plus umbilicus, of course you go for the umbilical access, put in the port, do the hernia, and on the way back, repair the umbilical hernia. So these, to my mind, are good indications. The advanced indication is the redo. Remember, in open surgery recurrence, redo, you go through all the scar tissue that the surgeon before you left behind, especially with the peritoneum, vas, and vessels. When you come from the inside, you avoid all that. You go directly to the peritoneum, and all you need to do is scrape off vas and vessels. So I think these are very good indications at any age. And the one thing where I'm very conventional is, and what I miss in all this discussion is a classification. I really believe, like we all surgeons, choose your battle right, choose the right operation for the right patients, that in inguinal hernia we think laparoscopy can do it all. What do I mean? I mean, ex-premi, huge inguinal, external and internal inguinal ring. Niehu's classification 3, for example. We all know that this takes a lot of surgical finesse to reconstruct the internal and the external inguinal ring. And by simply just doing a peritoneal layer on it, that doesn't solve the problem. And some of the recurrences are probably from those cases. So I opt for a stratification, not do them all, not the ex-premis with these huge hernias, where you need to reconstruct layer by layer. And then I think laparoscopy is a very good technique.
So regarding also the risk of recurrence, and you were talking about one of the points that I would like to ask you is regarding the age of the patients, neonatal surgery. Neonatal hernia, especially with the incarceration also. Do you have a special consideration for extracorporeal or intracorporeal technique? Or seeing also that with open correction of herniotomies, the rate of recurrence is very high, even 6 to 8%. What do you think about doing this minimally invasive surgery at this age? Which is a technique, and do you think also about the comment that you said if recurrences or in many series are related to this age?
Unfortunately, we have a little computer problem here. I do them all that are put under general anesthesia. which means that when the anesthetist choose caudal or spinal anesthesia, it's an open repair. But all the others, whatever the condition, are done by laparoscopy. For instance, if you have an acute incarcerated that you cannot reduce, most of the time the anesthetist will put them under general anesthesia, and you can do it. So I don't put other limitation. Now in infants it's a little bit different. There are some advantages. You can put the child transversely on the table with some form of elevation. This is on a heating neonatal table that will allow you to work from the head quite comfortably and to look in the same direction together. Now, as far as incarceration, one of the good advantages is that you can check the bowel once it has been reduced. Now, you will see that in this few weeks old child, the bowel is viable, but you will also see that the instruments look much bigger than in the first video I showed you. You will also see that the peritoneum is much thinner and friable, especially at the time of the closure. And this is where you like to know that there are studies that say you don't need to close it once it is dissected. But it can and is done significantly. Now, if you look at the literature about hernia repair by laparoscopy and recurrences, there seems to be worse result in older children, more recurrences in older children. And in infants, they seem to have less recurrences by laparoscopy than by open. So it's about the reverse of what you see with conventional surgery.
A question coming from the chat. How do you know, when you are looking to the contralateral side, how do you know it is, you are looking to a true hernia or just a dimple?
Yeah, perfect question. First of all, most of us always use a 30-degree scope. So you turn the scope and you scope the PPV, the patent processus vaginalis. Secondly, because of the insufflation of gas, you either see a bump on the outside indicating a hernia, or you don't. And the general rule is more than a centimeter is considered more than just a PPV and should be closed. So take a look inside and you will see how long it is. If you can't do that, take a look at the outside and you see whether the gas is actually elevated in the abdominal wall. And if in case of any doubt, you can enter an instrument, and once the tip is fully buried into the PPV, then it is longer than a centimeter, and most of us would consider that is going to the external inguinal ring, and then it is an inguinal hernia. Once it reaches the external inguinal ring, per definition, it's more than just a PPV inside the canal. Paul, do you agree?
I agree, but I don't hesitate to close, and this is why. In most laparoscopic series, roughly 30% of contralateral sides are patent. If you look at the metachronous number from the open surgery, the most optimistic would say 5 to 7%. Many would say 10 to 15% of metachronous hernia. If we admit that only the patent processus vaginalis will lead to metachronous hernia, it means that 1/3 to 1/2 of what you see will become a hernia in the future. So I do not hesitate to close them.
We have a question from Dr. Sharabi from Egypt, who is concerning about putting the knot subcutaneously because there is of granuloma for the stitching. And also, he asks about the risk of development of hydrocele after ligation of the sac.
Dr. Shalabi is a fine colleague, and of course he knows exactly what he's asking. Yes, Darius and CK both report that by burying the non-absorbable knot underneath the skin and the subcutaneous tissue, that some patients come back where parents say, look, doctor, there is a little dimple here underneath the skin, and they're concerned. So it is a small problem, but Dr. Shalabi is completely right in asking that it is a problem. the advantage of older children is that you can bury it deeper. But again, you leave the suture of both of these herniorrhaphy techniques by excorporal knotting underneath the skin. Good question.
Once again, I don't have any experience, but there is in the literature, there are two concerns about this knot. It's a granuloma, but also the potential pain, chronic pain that could come from having the abdominal wall caught in that knot. There are people that have reported a technique to drive the knot below the fascial and the abdominal wall to prevent this. It's, if I may, it's a bit Chinese, but it seems to be efficient. But I have no experience.
Dr. Nabila Talat from Pakistan is asking this question. What is the incidence of testicular vessels or inferior epigastric vessels injury during these pierce techniques or the technique of CK and so on?
Actually, there's no report about that. There's no report about that. No, I've seen it happen, and not in one of the series I quoted. Let's give CK credit and make sure that he's extremely honest in reporting anything. I've seen it happen, but this is not a major series, and this is just a personal experience. By the way, it's a problem. You have to be very fast and compress it.
I had two instances. One that led to very difficult hemostasis was in an extrophy patient with a completely distorted anatomy, and another one, well, we just grab the epigastric and coagulate them.
Well, Mario wanted to speak, but probably you have a cough or something like that. So what about the other hernias, direct hernias, crural hernias? Is it possible to treat them using laparoscopy? Which technique? Is it necessary sometimes to use a patch? And so on and so on.
François, we hoped that you would ask that, because Paul is keen on reporting how efficient laparoscopy can be. So thank you very much for giving us this shot.
Thank you, François. Well, what I would like to show is that you can do whatever you would do open by laparoscopy. So the laparoscopy is first and for all a diagnostic tool. And the belief that all hernias in children are indirect hernias is not true. There are direct and there are femoral hernias. In our little experience in Luxembourg, we found 1.3% of direct and 2.6%, that's 4% of all hernias, are not indirect hernias. Now, can the direct be repaired? Look, this is a baby that had a right indirect hernia, as always. Clinically, he had a bilateral, but you can see that the ring is perfectly closed, and there is a defect medial to the epigastric. That's a true direct hernia. So it can exist very early in life. Now, the defect here is the fascia, the transversalis fascia that has be weakened and released, and you can identify it and divide it and prepare it. So you see that you can actually do a very nice dissection. For the sake of time, if it works, I will just move it up a bit. Once you have identified everything, you can do a Bassini-like repair by suturing the conjoined tendon to the inguinal ligament, and thus have a repair of the floor of the inguinal canal, and not only a closure of the peritoneum. So it is technically possible. Now, if you look at femoral hernia, well, let's remember that one of the stuff that was initially done was to propose laparoscopy as a diagnostic for recurrent hernias, and this is a previous repair by open surgery, and the recurrence is in fact a femoral hernia. Now, this is not correct. This is not. Okay, I just need to show you. Now, I can show you the femoral hernia if you want. I think it's this one. No. So it can also be done for femoral hernias, but I think for the sake of time, we will just skip one more video. So for femoral hernias, also you can dissect and suture the conjoined tendon to the Cooper's ligament as a McVeigh repair from inside. It can be done.
Thank you. Just a comment, because Darius Patkowski is chatting with us when you are talking, you know. So we have some answers coming from him directly, and he says that among 800 cases, sorry, just 3 hydrocele and no testicular atrophy. That's it.
Yeah, and there's a good paper on his technique proving that there is very limited testicular atrophy. And to add on that, there is another paper about his technique that there is very little testicular ascent, secondary testicular ascent after herniorrhaphy. So it is a good technique, Darius, of course. Hey, thanks.
Well, thank you, Darius. Well, the truth is when you read the results of all the various techniques, the recurrence rates are always quite low. These remain good techniques, whatever they are. And the differences between one and the other is often minimal. So I think there again, as was said for the reflux surgery, one should fine-tune his skills with one technique and use it and adjust it to the situations.
So seems that laparoscopic surgery, it's a very interesting procedure, approach for the hernia. How do you explain then why most or many pediatric surgeons do not do it laparoscopically?
Yeah, there is a nice, in 2012, at the UPSA meeting, at the conjoined UPSA and BAPS meeting, actually, people were asked, why don't you? And interestingly, 80% of them said, we don't. 80% of the UPSA and BAPS attendants said, we don't do laparoscopy for inguinal hernia repair. We may be able to pull it, but otherwise I know it by heart. It's in the European Journal of Pediatric Surgery. And the reason for about 60% of them said too difficult. 30 of them said slower laparoscopy. And then they were about 30% concerned with damage to abdominal organs, vas and vessels. So there is a considerable reluctance, maybe in the European more than in the US. Let's see what Dan says. To say, yes, it seems sexy, but 80% don't do it because of major concerns.
I would echo that. In the U.S., it's very slow to make a movement. There are currently 12 people in my group, and there are 2 of us that do laparoscopic hernia.
Well, I'm just trying to pull. It's true. What is amazing is that among the reasons that were given on that survey from BAPS, there are injury to the vas and the vessel. This is the argument that we use to promote laparoscopy. There are injury to intra-abdominal vessels, and despite the fact that many of those responders were indeed involved in laparoscopy for other indications. So it is a bit hard to understand. I think a big part of it is the perceived increase in time for the repair. There are out there meta-analysis showing that no, the time is the same or even shorter for bilateral cases. The fear of cost, and as we showed, no, it costs nothing. And maybe the fear of not having the skills, which you will only get by doing it.
What about the fact of anesthesia? Because one of the concerns sometimes is general anesthesia of this part. But doing this procedure in an expert hand, with a very skilled surgeon that the surgery could be done probably in 15 or 20 minutes. What do you think moving towards less invasive anesthesia?
Well, two comments. One of the anesthetists in my institution is using laryngeal mask, unless I let the resident do the case. So when it is the senior surgeon, he puts a laryngeal mask after 1 year of age, and they just do fine. Now, the other concern is that the very small premature infants might be at a higher risk. The anesthetists are expecting their famous GAS study. They have an ongoing 5-year long-term evaluation comparing caudal and general anesthesia in infants for hernia repair. Let's say that the interim 2 years results are out. There seems to be no difference in neurological outcome, though the testing is insufficient. And they do have, during the first 30 minutes, 1 to 3%, 1% in the spinal group, 3 in the general anesthesia group of apnea, no difference later. So there might be less fair to have. Now, just one little experience. We had a new anesthetist a few weeks ago, and on the Monday was extremely excited because we were doing a duodenal atresia in a 2-kilo baby by laparoscopy. And on the Wednesday, he told me, no way, when I said we are doing a 2.5-kilo hernia. It was not difficult to convince him that, yes, we were doing it.
Thank you.
No, perfect.
Philippe Montupet wants to add something.
Thank you, Francois. It was a very interesting debate, and I have two short practical questions. As you know, Ciro Esposito and myself started with Felix Schirch in the 90s with the intracorporeal knotting for or hernia. But practical questions are, first, if we have to operate on 3-4 hernia in the morning, it needs 3-4 endoscope and 3-4 3mm set. And how do you manage, which is your choice in terms of endoscope, 30 degrees or 0 degrees? And second, how could you manage 3-4 hernia in the morning if you have only 2 sets of 3mm?
Well, I can, let me go for that. First of all, 30 degree, always. 30 degree, to scope the set. Number 2, as I said, I don't do them all. I try to find the wisdom in selecting patients. And if I have a preterm with a huge external inguinal ring, I'll do that openly. And then this 2-year-old with bilateral, I do it laparoscopically. And then I have maybe another 3-month-old from the pediatric intensive care unit, I do it open. And then I have a 4th case, which I do again laparoscopically. It's a matter of management. But first of all, patient comes first, right indication for the right patient. And yeah, is that a good answer to you?
And boy rather than girls?
That is an old discussion. That doesn't matter. If you do it right. And if you do it right, you can manage vas and vessels because as a pediatric surgeon, you're trained to do that. If you start and are afraid of the male internals, then you start with girls and get a feeling for the dissection of the peritoneum. But again, a technique must apply to both genders, and it does. Paul.
Dan?
About the sets, yes, I have 3 sets. As I said, I do not have limitation on except for the anesthesia. I do girls. It's very interesting to see the ovaries and confirm that you don't have the rare androgen insensitivity. It is quite easy, for instance, to pull an ovary back into the abdomen. And in those cases, it is very interesting also, you see the ovary coming back. Make sure that you don't grasp the tube, but the ligaments. And there it is. And then with this technique, it is also very easy to place the closure of the processus vaginalis at the right level. We know how by the open approach, it is difficult to find the right level and make sure that you leave the tube. So yes, we do girls too. And we have 3 sets, which usually if you put one Other case in between allows you to do 4 or 5 children by reconditioning one of the sets.
Can I ask you a question? We learned from you, Paul, that the herniotomy is the most common procedure carried out in pediatric surgery. So there's one aspect of training and education in pediatric surgery. How would you fulfill that with the laparoscopy? Or if we abandon the open procedure, how do we educate our pediatric surgeons?
Well, I don't have the right answer. I just can make comments that are more on a humoristic way. Do you need to know how to ride a horse to drive a car? Or do any general surgery program still use gallbladder operations? Do gallbladder operations open to make sure that their trainee know how to do it? I think it would be unethical to go back to open surgery for normal gallbladders. And it's true that the trainees in general surgery have so-called lost that training. Now, for hernia, it's a bit different because we don't have yet the proof that this is superior. So probably having a mix of open and close. Now, in most practice, like Holger and mine, where I do open the smallest babies that are not fit to be put under anesthesia, we have that difficulty that those hernias are usually very difficult for the trainees. Mm-hmm. So, yes, but they will be very comfortable with laparoscopic repair.
A question, we asked this question, but you did not answer, and Rafik Shalabi, our friend from Egypt, asked, do you use a mesh in some cases or never?
Oh, careful with mesh. This is a completely different discussion. We are only talking about the indirect, typically pediatric indirect hernia. We're talking about the typical patients, 0 to 3, 4, 5 years of age. They don't ever need a mesh. In case many societies, especially the American societies, they warn about the application of mesh in the abdomen because it causes a lot of damage. So you have to be extremely strict in indicating a mesh, and to my mind, a mesh is only applicable in the so-called adult operation, which means an adolescent, 15 years old, direct inguinal hernia. Yes, you have to be able to do a different operation, but again, if you don't cover the mesh with peritoneum, there may be fistulas all over, and a mesh is a really tight operation. So, if it's a pediatric operation, which I call pediatric, never need a mesh.
Yeah, I completely agree with Holger on this. And then, in fact, there's a renewed interest, or maybe a new interest, looking at the adolescent young adult population in the U.S. Remember, the most common hernia in males in adult populations are still indirect hernias, right? So there's an interest in whether or not high ligation alone in the adolescent young male should be done and not being put in mesh in. So that hernia society in the U.S. is now thinking about how do they go about designing a trial looking at high ligation alone without mesh in the young adult population. So I would agree there's no indication for mesh in a child short of something historically wrong, that's collagen disease or some other thing that just has to be managed.
And in case of huge hernia in teenagers, for instance, do you think there is a place for a properitoneal approach or never? Did you see something in the literature, for instance?
Well, there are only a few case reports. There was one at the ESPES meeting a few weeks ago where people would use the adult techniques like the tap or the tap to put mesh in those very specific and unusual indications. But once again, I think it should not become a routine in teenagers.
Can I ask one quick question? I know we have to probably move on, but in females, young females, where you have a patent processus that reaches the external ring, but you can grasp the patent processus and pull it all the way into the abdomen. do you suture that, or I personally just cauterize that and it just obliterates it, just squeezes it right down, and the sac is gone? I'm just curious about your thoughts.
I think you do what you always do to do it best. And what you're saying is just pull the nubbin of peritoneum to the inside. And again, you do what you do. Some people just throw a Röder loop across it, but if you're used, I'm sure that Paul will say, I cut it and I tie it. And I'm sure that CK will say, purse string suture. And Darius, he will poke it. So I think, that is the beauty, and it's been said when it comes to GERD before. The beauty is always perfectionize your technique, become better and better, and don't take shortcuts just because it looks different. I would do the same thing I'm always doing to guarantee the same safety for the patient.
One last question, because we're running out of time. And how do you perform your follow-up, seeing that many of the publications have this wicked point? How many years of follow-up are necessary to consider it a success?
It is extremely difficult. We routinely see the patient after 3 months, and we encourage them to come back if there is any problem. But it is very difficult to have, unless in a study we will call them back, but it is very difficult to have them come back at 3, 5, 10 years. Now, in the literature, we found one study from the Mayo Clinic looking at 50 years of follow-up. They were able to find just over 200 patients that had been operated 50 years before and call them back and find their final chart. What is interesting is that they found 21 redo groin operation, 2/3 of them being for direct hernias, and it was about 4% being recurrent indirect hernias. Most of those were fairly early, the direct being late in the follow-up. There is no proof that this incidence of direct hernia is different from the general population. In that 50-year study, they had 5% of infertility, which they quote is exactly what you expect in the general population.
But learning from Felix Scheer, coming back on that historic route, I think if you embark on laparoscopic inguinal hernia repair, independent of the technique, you have to embark on a very long follow-up, because the patients don't come in the first year, they may come after 5 years. And if you really want to academically understand this kind of operation, you must be dedicated to a long-term follow-up.
Thank you very much. We will conclude this second part of this masterclass, and then we will go to urology with 2 topics: nephrectomy, partial nephrectomy, total nephrectomy, transperitoneal approach, retroperitoneal approach, and then we will speak about pyeloplasty, trans or retro. We will discuss about everything at the end of your talk. So, Ciro Esposito, would you begin now? Thank you.
Thank you very much, Francois. We decided to divide the urologic part into different topics. I have the pleasure to introduce the first part, focus on nephrectomy and partial nephrectomy, and then my friend Philip will speak about pyeloplasty. First of all, we speak as for nephrectomy. As you know, this procedure can be performed mini-invasively using 2 different approaches, laparoscopy or retroperitoneoscopy. As for the indication for surgery, it is important before operate these patients to perform a scintigraphy, and nephrectomy, as you know, is indicated if a kidney function is less than 10%. As for the indication, the majority indication are represented by non-functioning kidney secondary to vesicoureteral reflux, or ureteropelvic junction obstruction, or multicystic dysplastic kidney. Other rare indications are represented by nephrotic syndrome, renal infection, or early pre-transplant nephrectomy. As for technical steps of both procedure, laparoscopy or retroperitoneoscopy, the steps are similar. We have to isolate the kidney and then the ureter. You have to treat vessels. You can clip the vessel or using sealing device or ligate them as you prefer. And then you have to ligate ureter and then section it. And then you have to remove the kidney. The choice of approach, it depends on surgeon preference, the patient's anatomy, and then the indication for surgery. As you can see in this table, there is the difference between laparoscopy and retroperitoneoscopy as for the both procedure. As for the indication, in yellow you can identify the indication in which laparoscopy is preferable. In case of vesicoureteral reflux, because in this way you have to remove all the ureter, you have to remove the ureter near the bladder, and easy to do it via laparoscopy. If you have a pelvic kidney, because it's difficult to dissect it via retroperitoneoscopy, and for sure in case of kidney infection or if there is a previous renal surgery, it's extremely difficult to create retroperitoneal space. On contrary, in case of ureteropelvic junction obstruction, probably retroperitoneoscopy is preferred, and also in case of multikystic dysplastic kidney. As for the team position, the patient is always positioned in lateral decubitus, and in retroperitoneoscopy the surgeon will stand on the back of the patient with the screen in front of it, and in laparoscopy the team is positioned in front of the patient. As for technical steps, you can see another table within the technique compare laparoscopy and retroperitoneoscopy. As you can see in yellow is indicated the steps in which laparoscopy is easier to create the space. It's easy to create the space in laparoscopy because you work in a larger space compared to retroperitoneoscopy. You can see the difference in the video after the slides. As for the trocar, it's easy to position the trocar in laparoscopy. As for hilar vessels, of the contrary, it's easier to isolate and treat hilar vessels in retroperitoneoscopy because, as you can see in the video, the elements are perpendicular to your screen and probably it's easier to manage them. As for the ureter, above all in case of vesicoureteral reflux, you have to remove all the ureter, laparoscopy is easier, and also for kidney extraction because you remove the kidney through the umbilicus. As for learning curve, for sure, laparoscopy is easier, the learning curve is shorter, and also conversion rate is shorter in laparoscopy compared to retroperitoneoscopy because you have 10-15% of incidence of peritoneal perforation. I have some videos to show you. You can see the difference. On the left side, you can see laparoscopy, the huge abdominal cavity. This is a transmeso approach to the kidney. And as you can see on the right side, retroperitoneoscopy. The problem is that retroperitoneoscopic space doesn't exist. You have to create them. For this reason, you need a learning curve to master this technique. As for hilar vessels, of the contrary, probably it's easier to isolate renal vessels via retroperitoneoscopy because, as you can see on the right side, in retroperitoneoscopy, the elements are perpendicular and easy to identify them because the kidney remain attached to the floor, and probably is technically easier to treat vessels using retroperitoneoscopy compared to laparoscopy. As for distal ureter, above all, if indication is reflux or if you have to remove all the ureter, in laparoscopy easier because you can arrive near the bladder, you can ligate and section the ureter. Compared to retroperitoneoscopy, in retroperitoneoscopy you live inside at least 3-4 centimeters of ureter and you can have problem of urinary tract infection, and sometimes you have remove after the surgery long ureteral stump, as you can see in the picture. As for the results, the conversion rate is 0 for laparoscopy. There is about 10% of conversion rate for retroperitoneoscopy above all at the beginning because you have the risk to perforate the peritoneum, you have to convert in laparoscopy or in open surgery. As for length of surgery, similar, about 1 hour for both procedures. The postoperative course is uneventful with no pain. The hospital stay is very short. As for the complication, rare complication in laparoscopy, the main complication in retroperitoneoscopy, as I told you, is the peritoneal perforation. Cosmetic aspects are very good for both procedures. In conclusion, giving you some consideration as for these two techniques. Laparoscopy and retroperitoneal nephrectomy are both standardized techniques. Probably laparoscopic nephrectomy is easier and learning curve is shorter compared to retroperitoneoscopy. Retroperitoneoscopy nephrectomy is technically more difficult because you work in a small operative chamber. For this reason, you have a small space to move your instrument. The main advantage of laparoscopy is to permit to work in a large transperitoneal chamber. As for the indication, as I told you, in case of reflux or pelvic kidney or infection, probably laparoscopy is preferable. Moving to partial nephrectomy, as you know, the indication to perform a partial nephrectomy is a duplication of renal system with one moiety that is poorly or non-functioning. This procedure was described in laparoscopy more than 20 years ago. In general, the pathology, you can perform an upper pole partial nephrectomy or lower pole partial nephrectomy. In general, the pathology in case of upper pole pathology is the obstruction, for lower pole is reflux. This technique is technically more demanding compared to nephrectomy because there are some complications reported because you can have urine leaks at the level of section of parenchyma, or you can have vascular injuries at the level of remaining moiety. For this reason, it's important to perform a follow-up for these patients. As I told you, it's technically more demanding than total nephrectomy. As for nephrectomy, you can perform this procedure via retroperitoneoscopy or laparoscopy. Some words as for the technique. In both techniques, the patient is positioned in lateral decubitus. It's extremely important before starting this kind of surgery to perform a cystoscopy is to put a stent in the normal ureter. In this way, you have the ureter and your eye along all the procedure, and you avoid danger for the normal ureter. As for the number of trocars in retroperitoneoscopy, you can use 3 trocars. For laparoscopy, it's preferable to use 4 trocars. You can see next slides. It's preferable to use a 30-degree optic, and to perform this kind of surgery is mandatory to use sealing device, because with this kind of device you perform a faster and safer surgery. The team position is the same as for nephrectomy, for retroperitoneoscopy on the back of the patients, and for laparoscopy in front of the patient. And for example, as I told you, in case of laparoscopic partial nephrectomy, you need 4 trocars, because 1 trocar to see, 2 trocars to operate, and the 4th trocar is important to lift up the spleen or the liver. As for the technique, in this table you can see the 2 techniques comparing, and as you can see in the different steps. As for the steps, probably in laparoscopy all the steps are easier: to create a space, to position the trocar, to manage polar vessels, to dissect the ureter. You have to remove all the ureter and then to remove the kidney and the ureter. Also, learning curve is easier in laparoscopy, and also the conversion rate according to the literature. As for the results of partial nephrectomy, comparing the 2 techniques, the conversion rate is higher for retroperitoneoscopy, the length of surgery is higher for retroperitoneoscopy. As for the postoperative core, is no pain for both techniques, and the hospital stay is about 2-3 days. In general, we leave a drainage for about 24 hours. The main complication due to technique is the peritoneal perforation, and the cosmetic aspects is very good. We publish a multicentric survey on this topic, and we can talk about at the end of my speech. Always some videos Probably, as you can see in these two videos, laparoscopy procedure, you have a larger view, and in laparoscopy you have to detach the colon, because in this way you can control in a better way the kidney and all the ureter compared to retroperitoneoscopy. As for the hilar vessels, as you can see on the left side laparoscopy, you have a very, very good view on the vessels. You can see the main hilar vessels. This is an upper pole nephrectomy, is extremely clear the anatomy, and you can manage the vessels safer probably compared to retroperitoneoscopy. And as for parenchyma, as I told you, to perform partial nephrectomy is essential to use sealing device, because with sealing device the surgery is faster, is safer, you have no bleeding, and after the devascularization you can section the parenchyma. There are different devices that you can use, the Starion, the ultracision ligature, that give always similar results, and all have FDA approval to perform this procedure. And for the distal ureter, the same problem as for nephrectomy. The advantage of laparoscopy is that you can arrive near the bladder. You can leave few millimeters of ureter. You can isolate the ureter in laparoscopy and ligate and section them near the bladder. In case of partial nephrectomy, it's important to follow up the patient, above all to check the vascularization of the remaining moiety. For this reason, as you can see in this picture, you have to perform an echo-color Doppler control to check if the remaining moiety was vascularized. One of the problems reported in international literature as for complication of both techniques is in about 30–40% there is a residual asymptomatic renal kyst. The etiology of this kyst remains uncertain. Probably is a seroma that takes the place of removed moiety. It is not necessary to perform a redo surgery to remove this kyst, because if you follow up the patient, it appears spontaneous a couple of years after the procedure. Some papers of the literature, this is a paper of 5 years ago, as for laparoscopic partial nephrectomy published by Nerli, as you can see, on 29 patients for complication but no conversion. This is another paper published by Marc David Lecoeur on retroperitoneoscopic approach comparing lateral and prone position on 48 patients. The length of surgery is higher, and above all on 48 patients yes, 10 conversion to open surgery. We recently published a multicentric survey comparing laparoscopic partial nephrectomy and retroperitoneoscopic partial nephrectomy, analyze 11 centers experience with 102 patients, 50 patients per each group, and as you can see, the conclusion is that laparoscopic partial nephrectomy seems to be faster, safer, and technically easier procedure to perform in children to compare to retroperitoneoscopic partial nephrectomy. Some consideration before concluding. As I told you, you can approach a partial nephrectomy in both ways, using laparoscopy or retroperitoneoscopy. Probably if you use laparoscopy, it's preferable to detach the colon to control the kidney and all the ureter. To perform this kind of surgery, you need special device for dissection. It's extremely important before starting surgery to do a cystoscopy and to position a stent in a normal ureter, and in case of reflux you have to ligate the distal ureter near the bladder. We prefer to always to put a drainage at the end of surgery, and you have to know that you can have some complication as this kind of surgery. In conclusion, analyzing international literature, partial nephrectomy is still performed in few pediatric centers. For sure is a technically demanding procedure. I think on the basis of the literature, laparoscopic partial nephrectomy is easier to perform compared to retroperitoneoscopic partial nephrectomy, and also the incidence of complication of laparoscopic partial nephrectomy seems lower than retroperitoneoscopic partial nephrectomy. As for trainees, the learning curve in laparoscopy is shorter than retroperitoneoscopy, and I think that the main advantage of laparoscopic partial nephrectomy is that you work in a large cavity and easier to manage ureter. Thank you very much.
Thank you very much, Ciro. So we go to the next presentation with Dr. Philippe Savay, who will talk about the pyeloplasty, bilaparoscopic approach, and retroperitoneoscopy.
Well, thanks, Mario and François. It's my pleasure to present what is rather, or what is considered to be rather a player for laparoscopic pyeloplasty than a real discussion on retroperitoneoscopic or laparoscopic approach. It's interesting that the first laparoscopic procedure was done by a gynecologist whose name was Kurt Sem. He was working at the University of Kiel, and he was not just doing the first appendectomy laparoscopically, but he also helped us in terms of inventing the pelvic training device, which is still in use in worldwide to perform practice in laparoscopic techniques. Laparoscopy for pediatric urology came pretty late into the game, and it was for many years it was just used for diagnostic purposes, like finding cryptorchidism testicles, and then later we came to ablative procedures like nephrectomy, partial nephrectomy, varicocele and stuff. And it was a little bit connected to German history when at the same weekend when the Berlin Wall came down in '89, the first oral presentation on a lap appendectomy in children was given in Berlin. Just 2 years later, Jeff Valab presented a huge series of more than 465 laparoscopic appendectomies. And that was the time when IPEG was founded in the early 90s. But it took until 1995 when Craig Peters, an American good friend and pediatric urologist, performed the first pediatric laparoscopic dismembered pyeloplasty. And it was Craig Peters himself who a couple of years later, or almost 10 years later, still described the laparoscopic pyeloplasty as being the ultimate challenge in pediatric urological laparoscopy. Why this? Or first, why do we operate on? We have to operate on in severe cases of hydronephrosis in terms of when differential renal function is decreasing or is already decreased, when we got significant obstruction, we got recurrent urinary tract infections, crossing pole vessels, or any special conditions such as horseshoe kidney. And the goal of the procedure is obviously to preserve differential renal function and also to improve urinary drainage. Why laparoscopic? Or why I prefer, or why I'm playing for the laparoscopic transperitoneal approach? Because if we do something in children, we would offer, or we would benefit from a familiar, standardized approach, which we use for all kind of other indications, and we don't have to change the approach just because of approaching the retroperitoneum. It offers a maximum of working space. Ciro has mentioned many points of that. It provides excellent overview, and it provides clear identification of the anatomy, for example, like for crossing pole vessels. And it's suitable for all age and weight groups, thus also for infants. So this is my major argument in terms of comparing retroperitoneoscopic versus laparoscopic approach, that with the laparoscopy we can operate on a 4-week-old infant or newborn, right as in the same way like in a 12-year-old. With the retroperitoneoscopic approach, we are kind of hindered in small children such as infants. The overview is excellent. Here you can just see into a massive hydronephrosis in a 8-week-old infant presenting with massive hydronephrosis, no urinary drainage in renal scintigram, and this is the opened renal pelvis, and you can see the dilated renal calyces in the background. It is very recommended to use stay sutures to kind of expose the renal pelvis prior to any resection of the renal pelvis in order to have a clear resection line and to be clear of the vessels, the renal hilus, and also to kind of really reduce the renal pelvis, which has been described in for the open procedure by Anderson and Heinz. And you can see this is again a child with a massive hydronephrosis, and you can see the relation of the dilated pelvis. And then what was our learning curve, that we didn't cut off the ureter at the same time, so we could use the resected pelvic portion of the specimen to hold on the ureter during the whole procedure until we have finished the anastomosis. You will see this in a second. So the next, which can happen, this is a small baby with a hydronephrosis with a significant intrinsic stenosis, and while pulling on the ureter in order to achieve a clear resection, we just teared it off. That can happen. It shouldn't be the case in all cases, but yeah, that's kind of a pitfall here. So the next thing is to incise the ureter at the site where we're going to do the later anastomosis, and then the spatulation. Then the instrument come from the other side in order to get an orthotopic approach into the ureter, and then spatulizing the ureter in order to get appropriate size to perform the anastomosis. Anastomosis then, or I prefer to prove also the lumen of the distal ureter. If I fit a 3 millimeter instrument in, like you can see it on the picture, and I can still read the letters on the instrument, I prefer then to use a 6 French stent. If I can't read the letters anymore, then I use a 8 French stent. That's my kind of a assessment of the lumen. Then right after the completion of the back wall, I proved that the anastomosis and the connection is wide open in order to avoid any obstruction later, and then followed by the front wall. This is another patient which was a little bit older and suffered also from a severe inflammation of the renal pelvis. But the offer or the advantage of the laparoscopic approach here is not just a good overview, but I can really perform the anastomosis in an anatomical correct way, also providing a very good inside view in the lumen of the ureter in order to stitch the urothelium with any stitch I do, and not to miss it or to just sew muscular layers together, which would be a problem to a proper anastomosis and good urinary drainage in the later follow-up. Then we use what we kind of introduced many years ago, a transrenal ureteral stenting, because we didn't want to compromise patients undergoing laparoscopic pyeloplasty and using a double J, and then having them undergoing a second anesthesia in order to do a cystoscopy to pull the double J out. So we kind of developed a technique where we go straight on through the abdominal wall with a curved kind of custom-made spear, then under view perforating the renal pelvis and the kidney, and pulling the spear and the attached splint outside the lateral abdominal wall. And then the blind end or the other end of the splint is just pulled into the abdomen, and then is going right into the distal ureter. So you can, after a week or so, you can just pull the splint out, and you don't need any anesthesia or any other kind of procedure to do that. That can be done on the ward and does not have any impact on the kids. And amazingly, in a series now overlooking more than 250 patients undergoing this procedure, I have never ever experienced any bleeding complication from perforating the kidney with that spear. Because, I mean, this is anticipating any questions, because that's what you always get asked when using this or proposing this technique. So the same thing we do for crossing pole vessels, which you can see here in an infant with a severe or significant hydronephrosis. This is obviously the case in this patient, and then you just, after disconnecting or dismembering the ureter and the ureteropural junction, then you just undergo the crossing pole vessel and kind of transpose the ureter in front of the pole vessel to avoid any obstruction after the anastomosis. And this is, for me, again, a very clear benefit of laparoscopic approach, where you can really identify the anatomy and avoid any obstruction, because it's not always that easy that you just transpose the ureter and everything is nice after that, because in one case we experienced that even with the vessel undergoing the ureter, it was still obstructing the ureteropural junction. One benefit of the laparoscopic approach, or which is in case of a horseshoe kidney, I think laparoscopy is mandatory, because you really identify the anatomy very clearly. You can see here the peristalsis of a horseshoe kidney in the untouched situs, and then after preparing it, you can still see the peristalsis of the massive hydronephrosis with the crossing pole vessels. The vessel's left side, on the left side in the picture are the testicular vessels. You see the gallbladder and the liver, all the topography, and then after preparing after further advancing the preparation, you can see where the problem was situated. This is the case in a horseshoe kidney. I will come back to this later. So what we did in the beginning, and not just to prove that this is technically feasible, which is obvious, but in terms of a functional outcome, is that we compared open to laparoscopic cases with a standardized follow-up. The laparoscopic transperitoneal approach was done in all laparoscopic cases, and in terms of hydronephrosis, we could see not significantly, but at least morphologically, a decrease in the grade of hydronephrosis. The differential renal function could be preserved in all patients, and most important, we could see a significant improvement in urinary drainage in the patients undergoing laparoscopic pyeloplasty. This was also true for a case series which we published years ago in the Journal of Urology for patients below 1 year of age, which is the major group undergoing pyeloplasty with infants having severe hydronephrosis. And later in literature there was evidence that our data were confirmed that this is not just safe and feasible, but offers comparable outcomes than compared to the open approaches. And then again, when I changed my job position some years ago, we kind of implemented the same technique which I have been doing at my former institution to another institution, and did just the same, and just wanted to know whether this is true for the new series. And again, we could show hydronephrosis decrease, very obvious here in an example of 4th grade hydronephrosis, and then the compared ultrasound after post-operatively. And then again, urinary drainage was significantly better. Again, an example where you can see it in the scintigram, preserving the differential renal function. So for the horseshoe kidney, again, laparoscopic transperitoneal approach is the most suitable. It offers excellent exposition and exploration, clear identification of the anatomy. This is the result after doing this patient. There's no doubt that cosmesis is superior. So in infants undergoing lap pyeloplasty, after a year, you need something to detect the small incisions. Laparoscopic pyeloplasty has been proven and been evident in literature that it provides cost-effective care as compared with open surgery. And maybe most interestingly, there was a paper comparing robotic versus laparoscopic versus open pyeloplasties and identified 5 primary outcome variables: success, reoperations, conversions, complications, and urinary leakage. And there was no significant difference between any of those procedures. So in other words, laparoscopic pyeloplasty for me seems to be the way to go. If we take a look at least at the United States and kind of assess trends and the effectiveness and outcomes, then it's interestingly that the majority is still been done open. And laparoscopic procedures are kind of having a stagnation. They are not increasing, they are not decreasing. And the most increasing number are the robotic pyeloplasties. But you have to take into account that those are most private patients undergoing the procedures in private hospitals and not in common or public hospitals, and obviously are much more expensive. There is evidence in the literature, not just in our papers, but in many papers published since then, that complication rates are comparable. They are approximately around 2.5%. And so in conclusion, I would say it's still a challenging procedure. It's a reconstructive laparoscopic procedure at the upper urinary tract, but it preserves differential renal function, it improves urinary drainage, it has comparable complication rates to other approaches, it is cost effective, offers superior cosmesis, and most of all, again, it's suitable for infants below 1 year of age. So thank you and greetings from Switzerland, and I'm happy to take questions.
Thank you very much for these 2 nice urological presentations. We will come back to Ciro, perhaps, for the first questions, but we can mix the questions because some may be asked to Ciro or to Philippe. It appears in your presentation, Ciro, that retroperitonioscopy seems to be really difficult for beginners. Probably. But don't you think that it's absolutely necessary for every laparoscopic surgeon to be able to perform this kind of approach for perhaps some rare indications, but they are good indications for retroperitonioscopy?
Thanks, Francois, for this question. Yes, I agree with you. I think that a pediatric surgeon, a pediatric urology, have to master both technique, retroperitoneoscopy and laparoscopy, and then decide which technique is preferable according to the indication for surgery and as for patient's age. In my experience, I started to perform nephrectomy and partial nephrectomy 20 years ago via laparoscopy. Then I moved to retroperitoneoscopy and then to move again to laparoscopy because at the end, in my mind, according to literature, laparoscopy seems easier to perform.
Yes, yes, of course. But don't you think that you have special indications? When I was thinking about some patients with Finlandic nephrotic syndrome, with the need of peritoneal dialysis for this patient. It's obvious, it's impossible to go through the abdominal cavity. You have to go by a retroperitoneal approach. Do you think you have numerous cases like that, or it's rare?
Analyzing the literature, the majority of indication, about 70% as in favor of laparoscopy and 30% in favor of retroperitoneoscopy, because, for example, the majority of the indication, you remove a kidney destroyed by reflux. In this case, there are huge ureters, you remove all the ureter. Or in case of previous infection or previous renal surgery, in this case, extremely difficult to perform retroperitoneoscopy because there are additions in retroperitoneal space and difficult to create the space. I think according to the literature, the majority of the indications is for laparoscopy, also if retroperitoneoscopy is a wonderful technique to perform.
And when you are speaking about retroperitoneoscopy, you have a lateral approach and you have a prone approach. What do you propose?
I have no experience in prone approach because I speak only of lateral approach, as I think the majority of pediatric surgeon and pediatric urology perform. Prone approach is an interesting approach, but I have no experience.
Chiro, saying in the nephrectomy and nephrectomy, what should be your advice for oncologic problems? Which approach and in which situations?
Yes, this is an intriguing topic. My speech will be focused only on benign pathology, but there is another point that is the indication to remove the kidney in case of tumor. There are a lot of publications in literature. This is technically feasible in laparoscopy. The problem is that for this kind of patient, you have to approach multidisciplinarily the patients. You have to speak with oncology to identify if laparoscopy is indicated. And there is no agreement as for the approach for this kind of patients. For this reason, it depends if your oncology agree to approach this patient with laparoscopy, but it's technically feasible, and there are a lot of papers on this topic. I think that the agreement is for benign pathology. For oncological patients, there is still a debate.
I mean, compared to open surgery, which was always mandatory to do a transperitoneal open laparotomy approach, if we consider laparoscopy or any MIS technique to approach upper urinary tract oncology indications, then I would strongly consider to do it laparoscopically. The problem is not to take the kidney out. That's feasible, and that has been done for like more than 20 years, also in pediatric patients. The problem is to fulfill any oncological surgical obligations like lymph node samplings and stuff like that, and I would consider this to be much more difficult in retroperitoneoscopic approach than in laparoscopic approach. And even then, it's not done in the correct way in a majority of cases, which have been carried out worldwide laparoscopically. So this is rather the problem of the laparoscopic approach or any minimal invasive approach for example, for Wilms tumors. But there are promising results now. Marc David Leclerc from France has published a series of successful and surgical correct nephrectomies and other groups. And now in the major tumor therapy protocol and study groups, like in the former COG and the SIAP groups, the indication or the possibility of doing nephrectomies with laparoscopy is now opened.
For sure, to perform a nephrectomy, a partial nephrectomy, you can remove the specimen through the umbilicus without any bag. It's not necessary to use a bag. Of the contrary, in case of oncological patients, you have to use a bag to position the specimen inside. And one of the critics to laparoscopy in case of oncologic patients, in case of nephrectomy, is that in case of tumor rupture, you can have a spillage of tumor cell with the insufflation. You can have a dissemination inside the abdominal cavity or at level of trocar orifice.
Chiro, thank you for your presentation. Rectal perinoscopy versus laparoscopy for managing of the collecting system after heminephrectomy. Is there a difference?
As for the collecting system, as I told you, the key point of both procedure is to position a stent inside the normal ureter, because is useful because it's easy to identify the normal ureter and to avoid danger to the normal ureter. And then you can use, at the end of procedure, you can inject, after to perform the partial nephrectomy, to inject a little bit of methylene blue to check if there is any leakage, and you can, if you have a leakage, you can position a stitch to close. For this reason, there is a double utility to check the normal ureter and then to inject the methylene blue at the end of the procedure. And we perform an injection at the end of this procedure to be sure that you have no leak.
In regard to that?
No, absolutely.
Chiro, you spoke about numerous pseudocysts after partial nephrectomy, and you said, I have never done something after that for these pseudocysts.
Yeah.
But perhaps some of these may be big enough to be treated, or
we had this problem, and we papered together with Imran Mustak that have the same observation. In general, when you follow the patients using ultrasonography, sometimes about 30-40% of patients you can find this kind of cyst. Probably these are seroma that take the place of the norm of the kidney that you remove. These cysts are asymptomatic, they are no problem. For this reason, our suggestion is to follow up this cysts. We have no problem, and in general, after a couple of years, this cyst disappears spontaneously.
Philippe?
If you allow me to make a comment on that, I agree with Shiro that in most cases there's no indication to do something, but we have to follow up those patients. And as we know also from literature, the most common complication or post-op complication after partial nephrectomy is urinoma. In terms of you opened up the remaining moiety system, or you didn't resect it completely, so there might be a urinoma, which is then not just presenting as a cyst, but as an increasing formation of fluid. And that has been an indication for us to go back to a patient. But as again, I would confirm what Chiro said, that we have to follow up those patients carefully and not just leave them alone with a cyst of whatever size and maybe increasing.
And for sure, as for nephrectomy, we leave no drainage and no procedure. As for partial nephrectomy, it's mandatory to leave a drainage, but in laparoscopy and retroperitoneoscopy at least for 24 hours to check if you have no problem and no leak.
Just a very short comeback about oncology. Coming from Brazil, Vilani Kramer said that he uses laparoscopy in oncology, but only by a transperitoneal approach, never by retroperitoneoscopy. And they never try partial nephrectomy in case of tumors.
I mean, if we take into account that not too long ago, partial nephrectomy was not allowed for Wilms tumors in open surgery, then we should be careful to use it very liberally now for laparoscopy. So I'm very kind of reluctant in opening this up just because we can do it, or what we suffered years at IPEG and ESPES meetings. It's feasible. Of course, it's feasible, but we are not fulfilling any oncological criteria maybe, and that might be devastating for those kids we operate on. So it would be not very responsible for us to do that.
Of course, I totally agree with you. It has to be done only in very serious multicentric studies, well prepared, well done, and never alone, just to try.
We have one comment from Manuel Lopez from Barcelona that says that in case when a lower polar is associated in vesicular reflux, at the same time the linear wire procedure can be performed at the same time after the nephrectomy. So this is a benefit of the transperitoneal approach also.
Absolutely.
So we published a couple of years ago a paper from my former institution where we kind of advocated a single stage approach for heminephrectomy and at the same time bladder reconstruction of the bladder neck, excision of ureter coeles if there were any present, and then neo-implantation of the ipsilateral remaining ureter, which is still a way to go. But obviously the pediatric urologists have become more reluctant in doing anything to duplex systems. So we have to be very careful with our indications for surgery for duplex systems anyway. But obviously, of course, this is possible, and if there is any indication to do it, then we should do it in the same time. Or then, for me, there's no reason not to do it.
I think that, in my experience, one of the main advantages of laparoscopy in partial nephrectomy is that you have a huge ureter, and it is impossible to manage this huge ureter in retroperitoneoscopy because you have no space. And in laparoscopy you have a large space, it's easy to identify them and to remove them. In retroperitoneoscopy you have no space to move. For this reason is one of the reasons for this reason laparoscopy is preferable.
Philippe, we love your very nice video presentation about pyeloplasty, and you explained that you were using a sort of drainage. It looks like a blue stent. It has the same advantages, but it's not a blue stent, perhaps less expensive. What is this stent?
You mean the brand of the stent? No, it's just what we call just a simple urethral stent, which we use for reimplantations, but also we kind of developed it also to use it in pyeloplasties. Like I said, we used a curved spare, which has a tip which is sharp to kind of perforate the abdominal wall. And then it's just a very flexible, soft material where we cut multiple holes in it at the level of the urethral-pular junction, so in order to drain the pelvis. And it's a very nice method which has been then published many times since then. I actually recently got a paper to review where somebody wanted to publish this for the first time. Very nice paper. We rejected it. But anyway, no, just kidding. This is a very, very easy technique. And again, as I mentioned in my talk, I think the major advantage is if we do it laparoscopically, and many people do then use double J stents, which implicates a second procedure, a cystoscopy to take it out. This is compromising the method. So if we doing it laparoscopically, we don't want to have a second anesthesia, and so we use this method.
So do you have any, I have two technical questions for you. Any technical pearls about recognizing how much the pelvis to resect when you're doing it laparoscopically? Because it's always a little bit of a hit and miss. You get your anastomosis done, and you have this big floppy pelvis that's left behind, or you take out too much. And then the second question is, do you always do interrupted sutures, or do you run part of the anastomosis?
Good questions. So the first one is the most reasonable questions ever, because when Anderson and Heinz kind of described the dismembered pyeloplasty, they kind of were requesting to really significantly reduce the pylon, because if you just reduce or if you just cut away the stenosis, then obviously the drainage won't be any better with a sac filling again. So there is a compromise, obviously, because if we resect it too much, then suturing it together will be a mess. So especially using interrupted sutures, because you have to really spend reasonable time on suturing the pylon together. So we do it, I kind of try to resect a reasonable part of the pylon, but it's kind of personal assessment. And I know, or I experience in my personal series, that if I don't do it, so the drainage is worse than I do it correctly. But there was a paper published by the group from Hanover, from Benno Ure, who kind of proved, which kind of proved that despite not resecting or not really subtotally resecting the pylon, the drainage and the outcome functionally, in terms of function, is good. So it will be an ongoing discussion. I would rather tend to resect more than we used to do in order to provide a good urinary drainage. And the second question on interrupted sutures, yes, I do interrupted sutures most of the time, even if it's work. I consider this procedure also as a training procedure. There's no better way to train intracorporeal knotting, which has to be watertight, and the distances have to be fair enough to provide watertightness. If then one of the sutures is not perfectly correct, you might have a little leakage, but that will probably close. If you do that with a running suture, you might end up with a problem. Now with the new generation of barbed sutures, I used them in a handful of cases. Amazingly, it was not very much faster than using interrupted sutures, but it was much more, technical handling the long suture, because you then need a real long running suture. And if, again, coming back to a huge pylon, so the case which in my video with this huge hydronephrosis, I used a barbed suture I did the anastomosis with interrupted, and then the rest of pylon, I used a barbed suture. Then it seems reasonable.
Thank you.
A new question coming from Manuel Lopez, Barcelona, for both of you. Any experience with stentless when you finished your learning curve?
Hey, Manuel, thanks for the question. Yes, never change a winning team. So I do think that now I might have finished my learning curve. I might. But still then the urothelium tends to swell after the procedure, and it might obstruct it in a way that the child will have some problems or flank pain or anything like that. And then anybody on the ward gets kind of uncomfortable with that. So we try to stent any patient. But I have to admit, there might be the case, or there might be indications where it's not necessary.
Hi Manuel, how are you? Yes, I agree with Philippe. I think it's always preferable to stent any patients, no doubt.
Perfect. We have another question from Canada. Dr. Batul asking if there is any experience of doing partial nephrectomy in angiomyolipoma in cases of tuberous sclerosis.
No, there is some papers published in literature with rare cases, but personally I have no experience.
Philippe, do you perform vascular H, and in which case?
No. And in no case.
I
know, I learned at the ESPES meeting just a couple months ago in Madrid that there is evidence that vascular hitch is doing a good job and provides improved urinary drainage. But still, and don't take it personal, I can't imagine it for myself. So I don't think it's a physiological way of treating it, despite the fact there is some evidence in literature, but I would never do it, and I don't want people in my institution doing it. So I do think that in case of crossing pole vessels or any extrinsic structure or stenosis, the dismembered pyeloplasty and the bypassing of the problem is the best way to treat it. That's my personal opinion.
Yes, I perform this kind of surgery, but it's important to select the patients. First of all, there is no prenatal diagnosis of hydronephrosis, are all teenagers, and symptoms starts after 8-9 years with flank pain, and you can discover this intermittent hydronephrosis, and if you perform a scintigraphy, you can have a loss of renal function. You can approach these patients in laparoscopy, and you can perform a vascular itch procedure, but it's important to exclude that there is an intrinsic obstruction, and at the end of procedure you have to perform a Lasix test to show that you have no problem. In case of doubt, it's preferable to perform a pyeloplasty.
Philippe, a question for you. Do you have some experience or do you have some comments regarding the retroperitoneal approach for pyeloplasty?
Yes, I'm happy to do so, but I have never done it. So the problem is that I've been always been trained in terms of doing it laparoscopically. I've never done a retroperitoneoscopic pyeloplasty myself. I have been people watching it doing. I discussed it endlessly with people like Jeff Vallard, also with Ala Elgonemi, but still, I was always convinced that laparoscopy is for me and for the setting I was working in and the setting I still work in with educating residents and fellows is the much more appropriate way to do. I consider it much more difficult doing it with a retroperitoneoscopic approach. I consider it to assess the anatomy and to identify the anatomy much more difficult. And again, one of the major issues is that it can't be offered to any kind of age and weight groups. So I'm reading the comment from Holger, who wanted me to comment on that too, and I appreciate that, but again, I can't assess it from the point of view of having an personal experience with it, but still are very cautious about doing it for any kind of patients. We can offer it laparoscopically.
Philippe Montupet wanted to add something about retroperitoneoscopy.
Yes, because the topic was sharing retro and transperitoneal approach, included the pyeloplasty, and just I was surprised, thanks to the webinar and the broadcast, nobody asked a question regarding retroperitoneal pyeloplasty. Why? I was surprised because it was a favorite approach in my experience for a lot of urinary surgery, except for pyeloplasty, because I didn't get so more times to have a nice experience. And I moved to watch and to see Ala Elgonemi team, and on several cases I observed a perfectly well-designed pyeloplasty in the same times. Of course, it took years and a long time to get such a level of experience, but it's really easy, perfect, and I was only surprised why in the chatting it was not a question about that.
There is just a question on the chat. It's coming from Austria via Strasbourg. And, I recognize Holger Thiel. Holger?
I wanted to ask the question, but not through the room, so I thought it would be elegant to put it into the chat. Now, the question is about these hybrid techniques when it comes to retroperitoneoscopically. And one extremely interesting technique comes from Italy. I think it was not Paolo Caione who invented it, but he made a nice publication about it, Mario Lima. Basically, you take one port retroperitoneoscopically to grab the PUG, and then you externalize it and do an external. And the fascinating thing about it, only in small babies, of course, and in huge dilated renal pelvis, is redundant enough to be brought up. But the nice thing about it is the operating time.
That's an out technique, as we said for appendectomy, for instance. And I'm sure that Ala Elgonemi is watching for this masterclass, and probably he is a little bit sad because we don't speak a lot about retroperitoneoscopy, that you said, and but that's the evolution, you know, and you explained perfectly this evolution. Do you want to add something, a comment?
I mean, it's the old discussion. I was once invited to Munich to operate on a laparoscopic pyeloplasty, while in the other operating theater an open one was done, and the very senior and very experienced surgeon kind of challenged me to go into a race or something, which I lost, obviously. So time is not always the issue, but it can be an issue. And then again, it comes back to incisions. And they told me, well, we do a little flank incision about 2 centimeters. My main critics on that is, and that matches also for the retroperitoneoscopic approach, where you pull it out. You pull something out, and especially in the pylon, where you want to have a straight, very accurate side-to-side anastomosis from ureter to pylon, I would consider this not to be a correct way in terms of reconstructing the anatomy, providing good urinary drainage. If you pull something out, pull it to another place, then cut it out, put it together, stitch it together, and then put it back. That's the same thing with the open approach, where you pull it out over a very small flank incision, and it's for me it's the same argument against the retroperitoneoscopic single port incision. But I have to admit, there are obviously, because coming back to the discussion or to the point talking about retroperitoneoscopic versus laparoscopic, The main disadvantage of laparoscopy is that when we were trained doing it open, it was a retroperitoneoscopic or avoiding to open up the peritoneum kind of approach, which now is transperitoneal. So we have kind of compromised the method again. And the second thing is then that there are now randomized prospective trials. One actual publication was in the Journal of the Society of Laparoscopic Surgery 2 years ago, where they did 50 retroperitoneoscopic versus 50 open, and there was the impression that the retroperitoneoscopic patients had faster recovery in terms of bowel movements, in terms of oral feedings, in terms of being able to be discharged versus the laparoscopic group. So I personally have to admit that probably the retroperitoneoscopic approach, apart from any technical issues, is the more minimal invasive, or the rather the less invasive one.
I had the pleasure to work with Jeff Valla, that probably is one of the pioneers of retroperitoneoscopy, also with Ala. I think that retroperitoneoscopy is a wonderful technique to apply for urological procedure. There are two main drawbacks. The first one is that you have a learning curve to create the space, because retroperitoneal space doesn't exist. You have to create them. For this reason, you have a learning curve to create the space, with risk to create a peritoneal perforation. The second drawback is that when you are in retroperitoneoscopy, you have a smaller space. The ergonomy is difficult to position more than 3 trocar. For this reason, I think that laparoscopy, as for urological procedure, has a larger diffusion, because laparoscopy is easier to perform, easy to teach, and learning curve is shorter compared to retroperitoneoscopy, also if retroperitoneoscopy is a wonderful procedure.
So, Philip, in the United States, there's been a big push for robots in children's hospitals, and most children's hospitals don't have robots because we as laparoscopic surgeons tend to do just traditional laparoscopy. But the pediatric urologists are really voicing their desire to have a robot specifically for this operation. And we saw a study you presented comparing 3 different techniques, of which the robotic approach was by far the most common, almost twice as much as any other approach up there. So can you give us the comments and your thoughts about the shift in robotics, and maybe not just in the United States, but across the world? Is this something that you think is necessary or needed, or is it more just a trend towards using robots in general in laparoscopy?
Thanks, Dan. It's a very good question. So maybe to illustrate it, asking Craig Peters, would you do it laparoscopically? No, he would refuse to do it, to do any case anymore laparoscopically. He's just doing it with a robot, because it's just too exhausting to stay in the OR and do it laparoscopically. So the robot offers, because this is a very standardized operation, it offers the perfect setting to use the robot. On the other hand, it's very expensive. It's not offering 3mm instruments so far, and the main target group we are approaching is infants. So in infants, I would really be very reluctant to put a 10mm camera or 6mm camera now in, and 2 5mm instruments, while I can use a 5mm port for the camera and 2 3mm instruments. And then again, it's the setting. And I mean, I could use the robot. My urologists offer it to me every day. They want me to use it, but the cost relation is just not reasonable. And that's the difference from Europe to the United States, where, at least as when I read this paper comparing robotic versus laparoscopic versus open, proved that most of those patients undergoing robotic procedures are in a private hospital setting, are paid by private healthcare providers or private insurance, and it's much more expensive than any open. That's also the reason most of the procedures in the United States still are being done open, because even laparoscopy then is more expensive.
I think that as for robotics, above all, for my topics, nephrectomy, partial nephrectomy, I think there are no indication. One of the main indications of robotic is reconstructive surgery. For example, in adults, prostatectomy probably is robotic prostatectomy is the gold standard. In pediatric urology, probably the main indication or the only indication is pyeloplasty because it's easier to suture in a smaller space using the robot. Probably a new field of development of robotic surgery will be the one-trocar robotic surgery because with one-trocar robotic surgery we have no problem of ergonomy as happens in one-trocar surgery.
Thank you very much. It's time to conclude now. We have to thank a lot all of the experts, and you presented us very, very nice talks. And we thank the chairman. For some of them are coming from far away, like Dan Arslier. So we are very grateful, and we thank you a lot. Thanks a lot to Philippe Montupet. Because you had the idea of this session 1.5 years ago, and it works. You succeeded. So, congratulations and thanks a lot. Thanks to the ESPES Group with Chiro, the president, the past president, Philippe Montupet, Paul Philippe, who is working a lot, and the treasurer, the secretary. Well, we have a lot of very important people coming from ESPES here on this table. Thanks to the IPEG, because this worldwide group is, I think, our example. We try to follow in Europe and in the eastern part of Europe. And so you organized very, very nice meetings, very impressive meetings, and sometimes it's very far away. That's why we thought it was necessary to have a European group, because it's not possible for us to go so far. But now with these master classes, probably everything is possible. Thanks to the IRCAD team and Jacques Maresco, we said he invited us in 1994, and every pediatric surgeon in the world, I think, know that IRCAD welcomed us very kindly and with a very high efficiency. So, and pediatric surgeons are numerous. I don't know exactly the number, but we had numerous chats today, so they are numerous to visit us. And to visit the WebSurge site too, you know the WebSurge site. So I would like to add, don't hesitate to send your very good video, your original video, your comments, what you want on this WebSurge site, because it's a very, very nice platform. And you have to know that this masterclass today, you will see it again if you want, either in the WebSurge site or in YouTube. So thanks a lot. We were very, very glad to welcome everybody here on the chat here in Strasbourg, and we hope we will be able to do it one more time. So bye-bye. Have a good evening or a good morning for everybody in the world. Thank you.